Good morning, everybody. So that was a wonderful talk by Dr. Lumba, and we want to welcome you to this year's liver meeting. So my name is Jeff Kahn. I'm from USC, and Steve Hahn and Paul Pokros are my sort of co-organizers of the meeting. And so we're going to get started right away. I thought last year might have been the best meeting we ever had, but I think this year we might actually top that. We have multiple thought leaders in various areas, so I hope everybody stays tuned. The lights are pretty bright back there in eyes. I don't know if that could be fixed, but I'm afraid that that might bother some people. Anyway, we have this passport, where if you walk around and go to the exhibitors, they can actually stamp your passport, and if you fill it out or fill it up and then turn it in, there are 3 really nice prizes that you can receive, and you'll get an email after the event tomorrow. So please visit all the exhibitors, and I think we'll just get started. So our first speaker is Dr. Gideon Hirschfield, who's from University of Toronto, and he really is a thought leader in autoimmune diseases, including PBC and PSC. I think this is a really exciting time for cholestatic autoimmune liver diseases, as we have some new treatments which on the market now that we can use in the clinics. And so I'm going to invite Dr. Hirschfield up to give us a state-of-the-art talk on PBC and PSC.
Thank you. It's a bit of a challenge, isn't it, when you say that last year was the best meeting and now I've got to do a better job, and then I've got to follow Rohit as well. And then the third thing is the lights are great. So let's just wait for my slides to appear. Some bits are going through there. Okay, let's have a look. Great. So it's a real pleasure to be here. So I've flown in from Toronto, where there's a little bit of snow, bit of mist here last night, but clearly much nicer weather. And what I'm going to do to open today is really just try and give you my sense of excitement about PBC and PSC, and why there is a lot of optimism for our patients, and there's lots that you can do. These are my disclosures. So, it all matters because it matters about real people. And real people have liver disease, and real people have common liver disease, and real people have uncommon liver disease. And actually, uncommon liver disease remains a disproportionate reason to have liver transplantation. This was a 25-year-old woman who came to my clinic. Okay, these are just her labs. There's no diagnostic mystery here. Yes, she's young, but clearly she's cirrhotic. All hepatologists strive to prevent cirrhosis. Okay, so here's a young woman who comes to my office with low albumin, high bilirubin, elevated alkaline phosphatase, low platelet count. All good hepatologists look at the platelet count first, okay, because that tells us a lot of what's going on. We use liver stiffness as well. It's not just in fatty liver, and her liver stiffness is elevated, and she tells me that she's had endoscopy overseas that shows portal hypertension. Her immunology is characteristic for PBC. So although it's rare to get PBC in this age group, in fact, her immunology is characteristic. She has an AMA positivity, she has anti-centromere positivity, she's SP100 positive if you do the second line test, and sensitive but not specific, she has an elevated IgM. So here we have someone with very impactful PBC by age and stage. If I was to show you a picture of her legs, you'd know the impact to her, because she had intractable pruritus, and she had scratched herself so much that she was scarred, and nothing that I would do would ever get rid of the scars, but everything that I could do could make a difference to her in terms of preventing further progression and treating her symptoms. So that's to anchor you in PBC. Then just to give you that broader picture about what are these autoimmune liver diseases and how do we think about them? Well, they're a family of inflammatory processes that either target the bile ducts or the hepatocytes. And in terms of biliary disease, they either target the small bile ducts, PBC, or the medium to large bile ducts, PSC. Okay, so PBC, female, AMA positive, middle-aged woman, lymphocytic cholangitis. PSC, more likely to be male, associated with inflammatory bowel disease, medium to large bile ducts. It's an inflammatory, stenosing, fibrosing cholangiopathy. It's Crohn's disease of the bile ducts, essentially, or scleroderma of the bile ducts. And then we've got autoimmune hepatitis, which is really obviously very hepatocyte driven. Behind the scenes, so to speak, it's your genome, your epigenome, your exposome, smoking, socioeconomics, and your microbiome, okay? And then bring forward, these diseases are very symptomatic for our patients. And yes, they're common rare. They're not ultra rare. All of you will see these diseases. PBC has an incidence of 1 to 3 per 100,000. PSC is somewhere between 0.5 to 1 per 100,000 incidence per year. Under the microscope, we get some clues as to what's going on, okay? This is just a little pictogram that we did for gastroenterology, okay? PBC, think of it as the lymphocytic cholangitis of the bile ducts. Okay, it is, these tiny little bile ducts surrounded by a necklace of lymphocytes that are punching tiny little holes in those bile ducts, making tiny little holes. Those tiny little holes let bile leak out. That bile is very inflammatory, profibrotic, and leads to the symptoms of cholestasis. Okay, in fact, you can see those tiny holes under the microscope if you look at the histology. That's PBC, the small bile ducts. PSC, as I told you, is concrete around the bile ducts, destroying everything, leading to the secondary biliary cirrhosis, but that concrete is toxic concrete, raises the risk of cancer. Okay, and we spend a lot of our time worrying about the cancer risks of our patients with PSC, which is not really something that we think about too much in PBC. And then autoimmune hepatitis sits in the middle, and real autoimmune hepatitis is steroid-responsive hepatitis that goes to normal. Okay, variant syndromes where you see a lot of inflammation between PBC and PSC is not real autoimmune hepatitis. It's inflammation that might respond a little bit to steroids, but it isn't really AIH. It's a consequence of the injury. And then the excitement comes from the fact that we have got treatments for PBC that have made a difference, and we want to bring that forward to making a difference for our patients with PSC. And everything is about clear diagnosis, risk stratification, early treatment, and prevention of late-stage disease and improvement in their symptoms. And our patients live with this aberrant cycle of aberrant immunity inflammation, cholestasis, and then progressive fibrosis. Okay, and this is like a feed-forward mechanism, and it's like watching a ball going around, and it gets faster and faster and faster. Okay, yes, that takes decades, but eventually then they've got end-stage liver disease and they decompensate. We're still pretty simplistic in our practice, and we rely on serum liver tests, our aminotransferase activities, ALT, AST, and that tells us that there's inflammation. And again, remember, ALT, AST does not mean only hepatitis. It goes with cholestasis. You see a woman with obstetric cholestasis, you don't look at the alkaline phosphatase, you look at the ALT and the AST, and that's the cholestasis. So we look at that, we see inflammation. But yes, the bile duct damage is alkaline phosphatase as a good marker. Gamma GT is a little bit more complicated because of its metabolic associations. And as the bilirubin rises, that means the disease is progressing. It's already moving faster than we'd like, but bilirubin and ALT phos. And then beyond things like you've heard about FibroScan, Shearwave, just clinically, we're looking at platelets and spleen size. And everything we're doing is trying to slow the cycle of immunobiology. Okay. Particularly for PSC, less so for PSC, dysplasia and cancer is on our minds. And this environment is very, very upsetting for the biliary tree and causes a huge amount of anxiety for our patients and the providers. Okay, we have a problem in autoimmune liver disease, unlike hepatitis B and C. Actually, it's very similar to NAFLD. It's a syndrome. Okay, it's a description. We don't know the causes of our disease. So in the absence of knowing the causes, what we do is describe what we see. Okay, that obviously impairs our treatments to be as good as hepatitis B and hepatitis C treatments. But we know that there's a close association between the liver and the bowel. We know that there's aberrant immunity. We know that there's aberrant immune circulation. We know that when the biliary tree is injured, that's not a good situation to be. Apoptosis, necroptosis, and senescence is causing a lot of the actual damage down the line. And we know that, it's more than just the biliary epithelium, it's also the endothelium of the sinusoids. And we know that there's basically an orchestra, okay? And that orchestra seems to get louder and louder, and our goal is to try and sort of at least dampen it down. In the absence of knowing the etiology, what we're trying to do is dampen down the consequence. And that's where we've got to much better molecular therapies. Ursodeoxycholic acid, the hepatologist's friend, is what can be best described as described of as a bile acid pool modifier. Okay, you take ursodeoxycholic acid and you change the contents of the bile acid pool, and that bile acid pool is more soothing. Yes, you can measure some downstream effects, but it's not a molecular therapy. Okay, first in the game was the FXR, and FXR FGF19 pathway. And bile acids are being sensed in the bowel. That's releasing FGF19, and that's having an impact through the FXR pathway in the hepatocytes. And so we've seen therapies for FXR, beta-cholic acid, other drugs, FGF19 drugs, and other molecules in the same sort of space. So that's one part of anticholestasis, okay, the FXR, FGF19 pathway, one part of molecular therapy. The other part of molecular therapy has been targeting bile acid synthesis, bile acids production, and other bile acid transporters through the PPARs. Very complex nuclear receptor hormones, delta, gamma, alpha, not only in the hepatocytes, also in the sinusoids, also in the cholangiocytes, but clearly when they are activated, there is evidence of anti-inflammation and anticholestasis. And so that really heralds where we've got to with our therapies, okay? So PBC, to remind you, usually female, usually middle-aged, usually AMA positive, and when not AMA positive, you can find other specific serology, usually elevated IgM. No need to do more than just an ultrasound generally, okay, because you're just looking for no biliary obstruction. Biopsy is interesting, but not practiced because you can usually make a diagnosis just on blood tests, symptomatic. And then now you see why the excitement. We've gone from bile acid pool modification, FXR agonism with a beta-cholic acid, off-label use of fibric acid derivatives, particularly in Europe and Japan. And now in the US, you have two licensed molecules, seladelpar and elafibranor, which are, PPARs that I'll go into in a little bit more detail. And because of this, okay, this journey, which also had a big impact, these patients are coming to your office. They're not coming to your ER room. Okay, yes, we see PBC on the transplant waiting list, but it's actually quite infrequent. Most transplant waiting lists outside of metabolic disease and HCC, it's PSC that's being on the list. PBC is less and less common. Ambulatory care, this is the art of hepatology where we prevent end-stage liver disease. And as that patient walks into the room, either the patient you've known for many years or that new consult that you got, abnormal liver test, what's the diagnosis, how can I help them? What you're doing is doing a risk assessment. So that woman, often can be man, walks into the room, and you're thinking to yourself, where do you sit on this barometer of risk? Because if we are to prevent end-stage liver disease, we have to identify the high-risk patients first, as early as possible, treat them so that they never, ever develop cirrhosis and complications. And we treat all patients, with that intent, but some of our patients have a higher baseline risk. They are younger, they have more fibrosis, they may have secondary steatotic liver disease, they don't respond to UDCA, they're GP210 positive, their FibroScan is elevated. And in that particular group, we're going to go that extra mile to make sure that we are really on top of their disease. That's not to say that the low-risk patients may not need second-line treatments, but it's to say that, as that patient walks in, you've already got your barometer ticking to make sure that you're speeding along the freeway to best treatment, okay? And you're going to listen. You're going to listen to their symptoms because symptoms really change quality of life, and quality of life is what matters to patients on a day-to-day basis because they have to live with this diagnosis for decades and decades, okay? And as we develop better treatments, and I'm pleased to say that we're not just targeting, pruritus, there are people doing trials of fatigue, and we're not just using drugs that would modify disease and improve pruritus, where in fact, drugs are being developed just for pruritus alone, then patient quality of life will rise. Okay. Intuitive care is appropriate. It is appropriate to look forward and not look back. Looking back, you would have been confused with all of these different treatment cutoffs and different risk thresholds for alkaline phosphatase in PBC. Okay, and yet we developed all of those with good intent, but intuition always told us that normal bilirubin, normal alkaline phosphatase must be associated with the best outcome. Okay, I realize it takes further evidence to go to show that when a drug does that, that's also making the patient live longer, but it's an appropriate starting point for your care to recognize the work of studies such as from the Global PBC Study Group that bilirubin values, even within the normal range, predict outcome, and the patients that do the best, no surprises, are the patients who've got normal bilirubin. Okay, so that can be your top goal. Okay, and then you can also substratify, and that's only possible by working together and having thousands of patients. In patients with normal bilirubin, alkaline phosphatase normalization is also associated with improved survival. Okay, so now you can use your intuition when you explain to your patient that you've used their blood test to diagnose them, you've used their blood test to risk stratify them, and you are going to be using their blood test to help you guide your treatment choices. And you're going to say to them that although everybody's different and there's all sorts of other comorbidities, in principle, I am looking for therapies that will get you to normal ALP phos and normal bilirubin. And that's my parameter broadly for treating you. I'll individualize it, of course, to you as the person based on your symptoms, based on your stage, based on your comorbidities, based on your age, based on your FibroScan. But the message is simple, that intuition does appear to be relevant. Okay. So you have ursodeoxycholic acid as your first-line therapy. It's still a good drug, okay? Many patients don't need more than ursodeoxycholic acid when dosed correctly, 13 to 15 milligrams per kilogram. It took us 20, 25 years to provide the evidence that it changed the outcome, because the outcomes are best for the patients treated earliest, and that takes the longest to prove, and you're never going to do that in a randomized controlled study. But fast forward to second generation therapies, obeticholic acid, licensed by the FDA in 2016, okay? The demonstration of clinical benefit comes from using surrogates, okay? Because we can't do true trials of outcome nowadays. They're just impossible. We have the original phase 3 clinical trial that shows a biochemical efficacy, a composite biochemical endpoint hit at around 48% in that clinical trial. We have long-term safety extension, patients receiving obeticholic acid where the ALP phos remains suppressed, okay? And then there are some cohort studies suggesting that if you take the patients who are in the long-term safety extension and you compare them, okay, it's not quite the same as a trial, but you compare them to historical cohorts, UK PBC, global PBC, that patients receiving obeticholic acid appear to have better outcomes. Okay, so that sets the scene for how to make a difference in second-line therapies in PBC. Adverse events from the POISE study. Pruritus is clear. So it turns out that IL-31 is an important cytokine for pruritus, and IL-31 has an upstream part where there's an FXR binding domain, and FXRs as a class, obeticholic acid as an example, but FXR agonists as a class increase IL-31, and that contributes to the pruritus seen with an FXR agonist. So pruritus is important. You'll also be aware that the label for obeticholic acid changed over time with the FDA to now exclude patients with portal hypertension to optimize the safest use of obeticholic acid. Is it even possible to measure real long-term survival for a new drug in PBC? Well, it was attempted, and it's been attempted for obeticholic acid, and it's going to be attempted for elafibranor and for seladelpar, okay? The real academic question is this even possible? First of all, will any of your patients stay in a clinical trial for 10 years, some of them whom are on placebo and some of them whom are on drugs, okay? Could you even think about which patients you'd put into a trial? We tried for Cobalt. This was obeticholic acid. These were very high-risk patients with PBC with quite advanced disease, and not surprisingly, it was impossible to show survival benefit in this single trial, which turned out to be a very large clinical trial, but was negative in terms of its clinical outcome. Okay, but patients on placebo opted out and moved on to commercially accessed OCA. So it's a real challenge for us in a field to move the field forward, and then sometimes wonder whether we're going backwards again because we can't meet the regulatory concerns for new drugs. Okay, other ways to demonstrate benefit, in fact, this paper has just come out in hepatology, I believe, okay, is to do purely synthetic trials. So this is a purely synthetic trial. We're using claims databases to identify patients with PBC and then to identify patients treated with and without obeticholic acid. And in this paper just published, it demonstrates that there is improvement from obeticholic acid. But this is not easy. How do you confidently diagnose that they've got PBC? How do you know why they got OCA? How do you know why they didn't get OCA? So not simple science, in fact, to demonstrate benefit of new drugs in rare liver diseases. Okay. So what about the excitement then? Why is it this meeting's exciting in terms of its sponsors? Why is it exciting in the US, and why will it be exciting across the world? It's exciting across the world, and generally because with OCA, people saw a way forward, people saw the opportunity to improve, and then selective treatments came looking at the other axis, which has been the most interesting to date, at least, of PPARs. Okay, this is the seladelpar response phase 3 pivotal international randomized controlled study. Seladelpar is dosed at 10 milligrams. It is a selective PPAR delta agonist. Okay, in this randomized controlled clinical trial, and the trials are nearly identical. 128 patients get 10 milligrams, 65 patients get placebo. There are 3 endpoints that I want you to think about for this trial and for elafibranor. There is the regulatory endpoint, which is a composite endpoint. Okay, alk phos less than 1.67, a 15% drop, and bilirubin is less than normal. That is your regulatory framework. And then is your key secondary endpoint is your intuition. Okay, normalization of alkaline phosphatase and improvement in pruritus in those subgroup of patients who are itchy. Okay, this is the high level results for seladelpar. Okay, 61.7% versus 20% have the composite biochemical response, a 42% drop in alkaline phosphatase. Normalization at 10 milligrams of seladelpar given once daily is 25%. 1 in 4 patients at the end of 12 months have normalized their alkaline phosphatase. Further long-term safety data has been presented at DDW and at ASLD, and that number goes up. Now, if you take a population of patients at need of second-line treatment and you use the biochemical entry criteria, you will discover that approximately a third of patients will have moderate to severe pruritus. In this clinical trial, as a key secondary endpoint, moderate to severely itchy patients had a significant improvement in their pruritus, and this improvement in pruritus was also seen across the whole patient population. As to adverse events, this is the seladelpar adverse events. You can see, in fact, that pruritus signal was actually picked up in the adverse events. The adverse event rate was 15% for pruritus for placebo and only 4.7% for seladelpar. But there are no significant, concerns here. Generally speaking, well-tolerated drug. Now, the other drug that's been approved by the FDA on exactly the same pathway and exactly the same way is elafibranor. This is the ELATIVE study presented by Professor Cowdley. Okay, you can see identical trials to all intents and purposes. Okay, similar inclusion criteria, similar randomization. This is 80 milligram dose. Okay, this is an alpha delta. So seladelpar is a pure delta. Okay, elafibranor is an alpha delta. For context, bezafibrate is a pan PPAR. Okay, so elafibranor is looking more towards, a bezafibrate kind of drug. Okay. Open label extension, more data will come out over time, but same endpoints. Okay, 51% of patients met the composite endpoint in this clinical trial. So you remember, obeticholic acid was 48%, seladelpar was 61%, elafibranor was 51% using the POISE criteria. Then looking at those intuitive secondary endpoints that we talked about, 15% of patients normalized in this clinical trial. In their key secondary endpoint of pruritus, they did not meet a predetermined agency agreed definition of an improvement in pruritus as per statistical plan, okay, but they do demonstrate improvements in pruritus in some of the other tools that they use, PBC-40 and 5-DH, okay. Their adverse events, very similar. Elafibranor looks very similar in terms of, the adverse event table. The only thing you can see is the elafibranor pruritus rate was 20% for elafibranor and 26% for placebo, so not quite, so that difference in pruritus did actually seem to come out in the adverse event table at least, but overall, there's not much discontinuation, not much concern. Okay, what are we actually doing in Toronto? Well, we don't have either of those drugs. Okay, we're in Canada, so I'm going to be watching you guys for years. Okay, what I have is urso, bezafibrate, and OCA. Okay, and in fact, we believe in combining those drugs for a very small group of patients. 10% of our patients need those treatments, need all 3. Okay, and when we combine all 3, what we're seeing is even better improvements in alkaline phosphatase, and we're reaching for that goal of intuition. Okay, but that's for that really small group of those very young patients who need new treatments. Okay, pruritus, just please think of it as a peripheral sensory neuropathy. I believe that's really what's happening. Your patients have got very irritable peripheral nerves, okay, in their skin that making their brain tell them to itch. Okay, this is not the kind of itch that gets better by scratching. That's the big difference. Okay, this is the linarixabat study from phase 2. This is an IBAT inhibitor. So in pediatric practice in the US already, you have 2 IBAT inhibitors that are associated with improvements in bile acids and pruritus for Alagills and PFIC, ultra rare diseases, very impactful. impactful for those few patients. This is an IBAT inhibitor in phase 3 development. And this was the phase 2 data. There was a press release from GSK at the end of AASLD that this clinical trial met its primary endpoint. This was a pure antipruritic therapy in PBC, a different population to, elafibranor and seladelpar, but the press release said that the clinical trial met its primary endpoint, improving pruritus. So the future is don't wait to fail. Okay, there's no logic to waiting to fail. The new paradigm is target therapy to patients, treat individualized risk, aspirational goals. Okay, make a difference. So if we can do that for PBC, we just have to do it for PSC. It's an absolutely requirement that we do something about this difficult disease. Covert, cholangitis, cirrhosis, colitis, cancer. Okay, this is the combination that your patients living with PSC have buried away in the medium to large bile ducts. Of course, we want cure, but we would accept control. Okay, we would accept preventing transplantation and minimizing cancer as a major step forward because we haven't really had that. Our patients, this is a real patient, live with terrible uncertainty. Okay, they have sometimes the most striking MRIs that you can imagine. Okay, and yet on the explants, they've got this concrete and no inflammation. They have pain. Okay, the bottom part on the bottom right is cholangioscopy. Are you surprised they have pain? That's what their bile ducts look like. That is obviously inherently painful. That looks like colitis, but it's in fact cholangitis of their biliary epithelium. And you're sending your patients to your advanced endoscopy colleagues when they have that dominant stricture, when their liver tests change and they've got new symptoms because you're worried about cancer. This was actually a 30-year-old woman, okay, that I recently sent for cholangioscopy. There is her cholangioscopy at the top. Fortunately, everything was benign, okay, but there was a huge amount of anxiety at the time because the stricture looked, progressive. And it's the question of whys, okay? It's not the question of, should we do better? We know we have to do better, but it's the question of why me? Why children? You don't get children with PBC, but you definitely get young adults with very impactful PSC. For an autoimmune disease, this is a disease of men, not women. That doesn't make sense. It's a very symptomatic disease. People always used to talk about the symptoms of PBC, and that was very important. I think it is very important, but talk to your PSC patients, talk to your young men with PSC, and listen to how symptomatic, how fatigued they are, and how much low-grade pain they've got. Why the biliary tree? Why the link with IBD? Okay, and cancer. It's so different to any other autoimmune disease. And our progress has been very slow in finding treatments because it's buried away in the large bile ducts. It's actually a very slowly progressive disease for the majority of people, which makes it very difficult. When you see that young adult, can you give them very powerful biologics, trying to prevent something that will happen 30 years ago? And how would you ever prove that? And would that patient take that therapy? Okay. This is just some data we just published in JHEP reports on the epidemiology of PSC. So this is Ontario. We're not as big as California, but we have a population now of 17 million, okay, of which this data set was 15 million. Okay, and actually what we found from this EPI study was that, for every one person living with PSC IBD, there's 100 living with IBD. So if you have a big IBD practice, every of your 100 patients with IBD, one of them's got PSC. And that's the patient with the greatest impact, the greatest reduction in survival. IBD therapies are just amazing, okay? And that's where our PSC IBD patients are lagging behind. And instance-wise, if you diagnose 50 IBD patients in a year, you'd expect to have one PSC IBD diagnosis, okay? We found, I don't know what you find in California, that there's a different socioeconomic class for PSC. It's a higher socioeconomic disease, okay? The patients are different, okay? And it's not surprising we found a significant morbidity and mortality. Okay, have genetic studies helped us? Unfortunately not. Okay, yes, there's genetic predisposition. This is a family, okay, with a very single phenotype of PSC, but nobody else, when they looked in the massive cohorts, has it. So we know genes are important, but it hasn't been that amazing opening of Pandora's box into this difficult disease. Okay. This is the latest GWAS studies, and we can see, interestingly, in genetics associations with smoking behavior and genetic associations with smoking behavior and PSC risks. So we're unpicking environment, okay? And the microbiome, the truth is it's not clear, but we know that the microbiome is different. We know that the species in the bowel is different, and that we presume is making different bile acid metabolites and making things different in terms of the colon and then in terms of the biliary epithelium. But we're a long way to using this in any practical terms. But bile acids themselves as a theme is important because they control immunoregulation. So bile acids in your colon and bile acids in your liver are changing immunoregulation. And that's why I don't want you to see a high ALT as autoimmune hepatitis. I just want you to see it as inflammation, because it's quite likely, in fact, that it's just immunoregulatory changes. We looked at what happened over 30 years to kids diagnosed with autoimmune liver disease, and we followed them up into adulthood because we had the hypothesis, that they present very inflammatory. It looks like overlap, but ultimately it's really just PSC when you get to see them in 30 to 40 years. Okay, and that's exactly what we see. That at the beginning, there's more patients with autoimmune hepatitis as their dominant phenotype. After transition and diagnosis into adulthood, okay, the number of patients where it just clearly becomes PSC is just much more obvious. It just takes a long time. So they have a big explosion at the beginning. It's very inflammatory. It looks like a hepatitis, but over decades, they merge into a biliary phenotype. And I think that's what you see clinically. And actually, when you take their livers out, patients diagnosed with AIH as a kid, okay, when you actually then transplant them as an adult, half the time their livers look like PSC, okay? And what's the transition point clinically? It's when they develop IBD. Okay, so over time, they start off with one phenotype, they then get their IBD, and then their liver disease changes. And I think that's what we all see in practice when we look at the patients that come to us in clinic. Okay, so yes, overlap is a big challenge for us, but really try and think of it in a different context to two diseases, in my opinion. Okay. And then our real challenge is the tipping point. With cholestatic liver disease, it's not a linear curve, is it? It's flat, 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 and then it's like a black piece of the ski slope and you go super fast. And we need to be treating our patients in the early stage so that they never get to the tipping point, but that means we have to have better surrogates to predict outcomes. Okay, are we there yet? No. Do we have exciting molecules at phase 2? Yes. Can we get the FDA to tell us how to do a phase 3 clinical trial? Maybe not. There is not agreement between academics, industry, and the FDA as to what a phase 3 clinical trial should look like. The FDA are leaning towards a clinical endpoint study where you have to make people live longer and have less events. That's not easy to do. Anyone who looks after PSC patients will know that they have a very, very different event rate and it's not predictable. This is aldafermin. We did the study back in 2017. It's an FGF19 analog, NGM282. What we saw was not an improvement in ALT phos, but we did see improvements in ALT, AST. We did see improvements in alpha and pro-C3. And interestingly, you see the same improvements in NASH. Okay, so this was actually a trial where the drug probably works in NASH, okay, but it didn't go forward commercially. Okay, what about fibrosis? That's the other theme. This is an oral, a non-systemic inhibitor of TGF-beta. This is the drug from Pliant 74809, bexotegrast. Okay, so the idea here is you reduce TGF-beta, also in early phase 2 studies. This is data presented by at ASLD. Okay, so it's not published yet, but this was data presented, I think this year was by Chris Cowdley, comparing, in a very early study, placebo versus different doses. At the highest dose here, there are some differences in ELF score. And so there are some signs that of early efficacy, but you need to go a lot further to take it all the way through to phase 3. Another late breaker this year, which I'll talk about tomorrow a little bit, CCL24 regulates biliary inflammation and fibrosis in PSC, and therefore there are inhibitors of this chemokine. And this was the results, which I'll talk about tomorrow in a little bit more detail, presented by Chris Bolus from UC Davis, okay, demonstrating some changes in liver stiffness compared to placebo in an early phase 2A clinical trial. So there is some optimism, okay. In Europe, this phase 3 clinical trial is fully recruited. This trial was not in the US. This is NOR-URSO. This is what's known as a colohepatic shunt. It leads to bicarbonate choleresis. It soothes the biliary epithelium, and the hypothesis is you'll normalize ALT phos more and you'll change fibrosis. Big trial. Biopsy is essentially the endpoint. Data will be presented at some point in the next 12 months, we believe. Okay, so to conclude, okay, you've heard the optimism about PBC. You can see why there's so much excitement, and now you have choice in your therapies. For PSC, much harder. We do our best to make a confident, clear diagnosis with compassion. Okay, we evaluate by elastography, bloods, and colonoscopy. We know about cancer and we sweat about it, and our patients live with that every day. Okay, but we have to think clinical research and trials because we are slowly progressing forward, but it's going to take collective effort to get patients into trials to really improve our understanding of disease, get better biomarkers, and into clinical trials. And with that, I'll say thank you.
Thank you very much. So our next speaker, you heard maybe an hour ago, Dr. Rohit Lumba, who's the Chief of GI at UCSD, and he's going to talk about MASH and MASLD abstracts from ASLD.
Thank you, Jeff, Stephen, and Paul. These are my disclosures. So I'm going to keep going from one abstract to another. This is the study that we were involved in for many years, looking at an FGF21 analog by Boston Pharmaceutical called efimosfermin. So the key thing with this FGF21 analog is it could be dosed once monthly and has a long half-life, 21 days. So this particular study is looking at biopsies at baseline and at 24 weeks in these patients, randomized to efimosfermin 300 milligram every 4 weeks versus placebo. 84 patients, 1:1 randomization. They had biopsy at baseline and biopsy at 24 weeks, along with MRI PDFF at baseline and at 16 weeks and at the end of treatment. And then some of these patients are being followed long-term as open label extension. Patients included in the trial had to have NAFLD activity score of 4 or higher, overweight at least with a BMI of 27, MRI PDFF of 8%, AST of 25 or higher. And then the primary endpoint here is looking at safety and tolerability, but of course we're looking at both MASH resolution and fibrosis improvement. So that's the setup for the trial. These are the results. To the left, I'm showing you MASH resolution without worsening of fibrosis, 68% on treatment compared to 29% on placebo. If you look at fibrosis improvement, it's 45% versus 21%, so 24% treatment effect delta. And then if you look at both fibrosis improvement and MASH resolution, that's 39% versus 18%, although that wasn't statistically significant. Then you also want to look at those just who had stage 3 fibrosis at baseline, and you see that the drug worked in that group of patients as well, with MASH resolution 57 versus 29, and then fibrosis improvement 64 versus 29%. And then 50% had improvements with both MASH resolution and fibrosis improvement, and 21% on placebo. You can see the placebo benchmark in each study might be different. Why is that? It's really because how pathology is being assessed in each trial. Therefore, you can't do a comparison that, okay, you're seeing NASH resolution 68% here, and in another study you saw 35%, that drug is directly inferior. That's not how we look at relative efficacy. There are ways to adjust that and still come to relative efficacy, but I want you to think about each trial in itself and then the treatment effect delta. This is looking at MRI PDFF reduction. So this rule of 30% came from UC San Diego, and basically it's now the gateway for drugs to be moved from 2A to 2B and beyond, and it's true here as well. 79% of patients treated met that criteria, and only 20% of placebo. We also call something as super response, which is 50% PDFF reduction, which is if you started with, say, 30% fat in the liver at baseline, at 6 months, it is down from 30% to 15% absolute. That's a 50% reduction. That patient has about 10 times higher odds of NASH resolution. So that's helpful because you don't have to biopsy that patient at week 12 to then develop a plan that what will happen at 24 or 1 year. So that's how it is being utilized. Again, that was true here as well. And there were some patients who normalized their liver fat that went below 5%. So 5% is the cut point. We say somebody has hepatic steatosis on MRI. Looking at absolute liver fat reductions to the left, ELF score we talked about earlier this morning, you have improvements in that as well. And then liver stiffness on FibroScan, you can see that you don't really capture that on the FibroScan at 6 months, and that's why typically you don't want to be repeating that every 3 or 6 months. in your practice, because it will cause confusion, because you'll think the patient is improving just because there's a decrease by 1 or 2 kilopascal, and you might think the patient is worsening, and that can be very troublesome if the liver stiffness value is up next time the patient comes in. And therefore, don't cause that confusion. Don't repeat that every so often, but actually wait for a year, in my opinion. This is looking at ALT and AST responses. You saw improvements with that as well. So I think this is good proof of concept with less than 100 patients. We're showing you can improve steatohepatitis, both NASH stage 2 and stage 3 fibrosis. So a larger and a bigger trial, an international trial is needed before we look into it. Side effects are, predominantly GI side effects with FGF21, and that's what we are seeing, here as well. Moving on to the Maestro NASH trial. This is looking at resmetirom versus placebo, 100 milligram dose versus 80 milligram versus placebo. This is to your question one that you asked. These are some of the patients who were already on GLP-1 analog. That's the middle column, and 137. And then to the right are those who were on SGLT2, 130 of them. And total is 647 patients here. And these are the diabetic subset in the Maestro NASH trial. So to the left, I'm showing you data on MASH resolution. So the first set of numbers are GLP-1 analogs who are on GLP. And to the right in the first top left are those not on GLPs. You can see that there's no difference between your MASH resolution responses. Then you go to the right top corner for fibrosis improvement with GLP or no GLP at baseline. And again, there's no difference. So if somebody's on GLP already, you can add resmetirom, we'll get the same response. Second, at the bottom left, you're looking at SGLT2 inhibitor. If they're on SGLT2, you got similar responses. And if they're not on them, you got similar response in terms of what you would expect. Same thing is true for fibrosis as well, whether you're on SGLT2 or not. And so I think that's helpful among these patients with diabetes within the Maestro NASH program. Now this is, I think, helpful because we talked about lifestyle intervention and importance of losing weight and diet. Here you can see if you lost weight in the program overall, you had a similar response. To the right, if you look at 5% weight loss at week 52 and a repeat biopsy, you're looking at a greater response, but you also see there's an increase in the placebo responses as well, so which would be expected. So regardless where you are, you're going to change your threshold for improvement across the board for NASH resolution fibrosis improvement. The way I see these results is that I think it's really important that our patients do pursue lifestyle intervention. And when we are treating them, we talk to them about, this particular importance of there. You put them on resmetirom, say it's still very important that you try to, adhere to a good diet and, reduce your caloric burden, try to lose some weight because it'll be beneficial. The bottom is, if they don't lose any weight, you're still getting benefit to the patient. And so it's not discouraging, even if they were not gaining weight, I think it's important. So I think monitoring that is still important for our patients. So hopefully this is useful in your clinical practice as I discussed. This is looking at Harmony data, which is another FGF21 analog by Caro called efruxifermin. So in this particular study, patients were randomized to placebo, 2 different doses of efruxifermin, 28 milligrams sub-Q weekly, and efruxifermin 50 milligrams sub-Q weekly. Patients had a biopsy at baseline in week 24, and then they had a 96-week biopsy, and so patients were continued on treatment for 96 weeks. So we have 2-year data on a FGF21 analog. Patients had to have stage 2 fibrosis or higher. Some of the other criteria for inclusion are listed here as well, that you can use in your practice now, in my opinion. So if you see what we've done across the board in multiple trials is you want to have features of metabolic syndrome, you want to have a liver stiffness of at least 8.5 kilopascal, and then those patients are underwent a biopsy. So your likelihood of having disease is much higher. And in some trials, we use a AST of 25, others we don't, but I think that can be useful in your practice. Why am I telling you that? Well, when you're looking at a patient, whether you should think about starting resmetirom, you can use actually these factors because they'll be helpful. So you can see the majority of these trials, the threshold already at 8.5. Therefore, that 8 is probably too early. So then you bring in and then look at the results of the biopsy with this FGF21. To the left, I'm showing you placebo data, week 24, and then the week 96 is the solid one. The gray here is the placebo group. The light blue is the efruxifermin, and then the purple or dark blue is the 50 milligram efruxifermin. And you can see there's a clear uptick in terms of improvement in fibrosis as we continue treatment. And the idea was that, well, if you only treat for 24 weeks, would you see improvements? Or would you see that there's no further benefit of the drug? So it looks like there is continued benefit, and you can continue to see improvements in disease. So if you look at both fibrosis improvement and worsening, you're seeing from 24%, 46% to 75%, a good dose response from placebo, 28 and 50. Now, what we are looking at here is those who had a baseline biopsy and end of treatment biopsy. When we are typically looking at results of the study, we'll look at all patients who were started on treatment and what happened to them, and that's called intention to treat. And so that's to the left. This is the bottom panel that you see, not the bar. And there you can see then the treatment response is 19%, 30%, and 49%. Why is that important to see? This is important to see because sometimes when we only look at completer analysis, we tend to overestimate the benefit of a treatment. So in real world, this is what might happen where you'll start patients on treatment, but many may not continue all the way. So both of these results are helpful because if your patient continues for 2 years, this is the benefit you're going to see. If you start everybody, how many are actually able to continue the treatment? That's at the bottom. This is looking at, stage 3 versus stage 2. You're getting a pretty good response. And I think with the darker bars, you can see that higher dose gives you slightly better results. But in type 2 diabetes, there's no major difference. PNPLA3 genotype, you can see you can get, pretty good response, and you see a dose response with that. And these data are also important, and we can discuss that in Q&A or panel discussion later. To the right, we also, they also looked at Q fibrosis assessment, and the Q fibrosis assessment is a way of quantifying fibrosis from 0 to 1. On that scale, they started seeing improvements with a modality called histoindex for automated AI assessment of biopsy. These are side effects that they observe. Again, they're predominantly GI side effects. One thing with FGF21 that we see is there's an increase in appetite. So patients actually eat a little bit more, but there's no weight gain. Actually, there might be a little bit of weight loss. You can have about 1 kilogram of weight loss or so. So no significant change, but there's an increase or change in appetite. And you also, there's a potential impact on your eating behavior, pattern of food. There's a potential change in alcohol consumption as well, although that hasn't been assessed in these trials yet. They noted a decrease in bone mineral density at 96 weeks. That hasn't been reported by how much. So we'll look into the paper once that's available. If you look at ELF improvements, there are improvements in ELF, and you also see improvements in liver stiffness assessment with continued treatment. These are numbers looking at those who had a 30% or greater improvement over 2 years with liver stiffness, and many of these patients are seeing those improvements as well. What if the patients started above 10 kilopascal, went below 10 kilopascal, and you're seeing that as well, and that's a helpful response that your patient is improving, and you can use that in your practice. So I think 2 years of treatment with NASH with FGF21 is leading to benefits. This is Synergy NASH data that we presented based upon tirzepatide versus placebo trial that we discussed actually post DDW. And so here you can see tirzepatide treated with 3 different doses, 5 milligram, 10 milligram, and 15 milligram sub-Q weekly versus placebo. And we genotype patients for PNPLA3 at baseline. And so the risk allele is the GG allele, which is really common in Hispanic ethnicity and also in our patients that we previously talked about. So this is important that when we looked at response by genotype, we noticed that you had a differential response. So if you look at the body weight changes, there aren't any significant difference if you see across the board. You lose body weight, but when you start looking at PDFF responses, the PDFF responses are different as an idea that gives you what will happen on histology that I'll show you. So if you look at fibrosis changes to the left, if you have GG genotype, you tend to see lesser improvements on fibrosis. What about MASH resolution? If you have GG genotype, you see lesser improvements, on MASH resolution also. But you can see that is also true for placebo. So the idea is that when you're using tirzepatide or GLP-1 analog, there are no GLP-1 receptors in the liver. These improvements lead to improvements in liver histology related to weight loss or extrahepatic benefits of these drugs, potentially leading to secondary benefits in the liver. But you're going to get a lesser response in those who have GG risk allele. Data is not being shown, but there is data available from other studies imputed that this might be true for PNPLA3. So in future, it's possible that we might modify, maybe in 4 to 5 years, that we may choose therapies based upon somebody's genotype or genetic risk score of progression. And I think that's where we will move probably in 5 years as the field matures with number of drugs coming along. This is looking at Maestro-NASH data, impact of NASH genetic background. And what I wanted to show is to the left bottom, you can see the PNPLA3 genotype data, no mutation, heterozygote, homozygote at baseline. And then you can see HSD, 17B13. This is a protective genotype. And then TM6SF2 increases the risk for liver disease due to NASH. So this is just the patients, how we saw them with different genotypes within the Maestro-NASH population. This is looking at fibrosis response. And what we are showing you here is that it didn't matter if you were PNPLA3 homozygous, heterozygote, or no mutation, no risk mutation, your response were similar to resmetirom. Similarly, no significant difference on HSD and no significant difference on TM6SF2. So this tells us that when you're using resmetirom, which is a thyroid hormone beta receptor agonist in the hepatocyte active, leading to increase in beta oxidation, this therapy is effective in those who have PNPLA3 homozygosity. So now you can use as to why this might become important in future. Now looking at synergy NASH data in terms of tirzepatide back, and I wanted to cover those genetic data back to back so you understand that there are certain therapies would have a differential response and others won't. Now looking at synergy NASH in terms of, can we assess treatment response and how we can better quantify it without repeating the biopsy? So again, we had 3 treatment groups versus placebo and a biopsy at week 0 and week 52. What we are looking at here is that you have a pretty robust ALT, AST, GGT, NIS2 and NIS4 responses, MRI PDFF responses, corrected T1 responses, which is an MRI-based modality that can also tell you the patient has NASH and whether the patient are improving. CK18 are also important, and they're improving. ProC3, a fibrogenesis biomarker, improves. ELF improves. FIB4 improves, and there's an improvement in VCT as well. And so you can see that these improvements can track both fibrosis improvement as well as NASH resolution. Looking at DGAT2 inhibitor, this is a the phase 2B program that we've developed from the very beginning. Companies based in Carlsbad here, Ionis. So they have a DGAT2 antisense inhibitor that basically blocks the signal from this gene in the liver and blocks this enzyme in the hepatocyte. So very specific treatment. And the way we developed the trial is we baked in a 2A trial into it, and then we picked the dose, and then we continued the higher dose based upon efficacy. The lower dose was dropped. And then we had a biopsy at baseline and at the 12-month time point, and then a PDFF and MR elastography assessment. Patients had, NASH stage 1 fibrosis or stage 2 or stage 3 non-cirrhotic. These are the results. We looked at NAFLD activity score that was presented at EASL. Significant results. To the right, I'm showing you the data on stage 3 fibrosis that was presented at ASLD. Placebo, a light green, and then all patients listed here at baseline. These are the results in stage 3 patients. So you see improvements in NAFLD activity score, both ballooning and inflammation improved, MASH resolution 30% versus 15%, fibrosis improvement 46% versus 30%. We also see pretty robust PDFF responses, particularly super response, which is dose dependent. And as you continue treatment, you see an increase in PDFF responses. This is looking at slight decrease in hemoglobin A1C and also improvements in ELF. So this drug has a positive phase 2B, and we're planning a phase 3 program with DGAT2 inhibitor. And this could potentially be used as a combination approach as well. This is looking at Viking, which is also a San Diego-based company with the phase 2B program that are thyroid hormone beta receptor agonists. And we've been involved working with them for 10 years now. Several different doses versus placebo. And this is baseline to liver fat changes. We saw significant improvements in them. These are the results on the biopsy. Significant MASH resolution compared to placebo, up to 75% versus 29% on placebo, and fibrosis improvement 57% and 34% on placebo. So both are significant. And again, we're thinking about a phase 3 program. This is end of phase 2B data. These are the PDFF reductions. You can go up to 88% improvements. Again, side effects are really, GI side effects that we see with the thyroid hormone beta receptor agonist. This is looking at Essence trial. This is the semaglutide versus placebo. You have patients randomized to 2.4 milligram versus placebo, 2:1, 800 patients in the trial. And so this trial is very well powered to look at histologic benefits. And then they also preferentially included patients who had stage 3 fibrosis in this trial. And so 69% of patients in this trial have stage 3 fibrosis. And these are important things as we discuss the results. These are the baseline characteristics of the study population: 534 on treatment, 266 on placebo. The weight effect, there's no genotype data that's available in this program, so we can't comment on that. We see the primary endpoints are listed here. Semaglutide is dark blue and placebo in gray, 63% versus 34%. How these data are presented is resolution of steatohepatitis. You see EDP response. So it's an estimated benefit that's been presented. What they've done is, as I told you, you have patients starting on treatment, but if they don't finish, in traditional analysis, those who do not have end of treatment biopsy, we call them non-responders. In these analyses, those have been equated to a placebo response. So if you didn't have an end of treatment biopsy, you are equal to 34% response for that group. And that's how you are factored in. So this gives you a slightly attenuated response. Regardless, that is not something that you cannot do. It's reasonable to do in studies where you do have patients, not completing treatment with treatment versus placebo. So you see significant results both for fibrosis improvement and NASH resolution. This is body weight change about 10%. Again, resolution of steatohepatitis is significant with improvement in liver fibrosis also, if you look at combined response. And patients also had improvement in body pain, but we don't know exactly where this pain is. So I think that could be something important to see that our therapies are effective. These are ALT and AST and GGT improvements that we routinely use in our practice. You can use them with SIMA as well. This is looking at liver stiffness improvements over 72 weeks, ELF improvements, and PRO-C3. You can see that you don't want to be repeating liver stiffness earlier. I think 1 year time point might be reasonable. ELF you could do probably in 6 months, and PRO-C3 again 1 year. These are some of the cardiovascular benefits that you can see: improvements in blood pressure, hemoglobin A1C, C-reactive protein, as well as some benefits on HDL. These are the side effects. Again, you can have hypoglycemia, you can have nausea, diarrhea. These usually come in early, develop constipation. So the way to augment that is we slowly titrate the dose up over 20 weeks. So that's very important. If you start using it in your practice, do not start with the bang of 2.4 milligram. You will not like it because they're going to call you and stop all the treatment. So you want to start low and slowly build it over several weeks. So be patient with the patient and don't push to 2.4 milligram early. And so those are the most important things from this. So in summary, MRI-based biomarkers are helpful in predicting histologic response. SIMA leads to both fibrosis improvement and NASH resolution over 72 weeks based upon these data. GLP-1 response is PNPLA3 dependent. However, resmetirom response is not. Resmetirom and GLP-induced weight loss may further improve response. There are several new therapies that are showing promise for treatment of MASH-related fibrosis, including FGF21, thyroid hormone beta receptor agonist. We did on FASN inhibitor. I didn't present given the time constraint. GLP plus GIP, GLP plus glucagon agonist that we'll discuss in future meetings here. Thank you.
Okay, our next speaker is Jennifer O from Scripps. She's the medical director of the HCC program there and a transplant hepatologist, and she's going to be talking about the updates in HCC and abstracts from ASLD.
Right. Good morning, everybody. Thanks for having me. So I'm really going to talk about the updates. I have no disclosures. So I'm going to spend a good amount of my time just talking about updates and screening. And this was actually a big focus at the meeting this year. The annual academic debate actually touched on this topic of who really should we be screening. There are the ASLD guidelines, which obviously state everybody who is cirrhotic, those with chronic hepatitis B at certain age groups. But, you know, there are those higher risk populations such as people with treated hepatitis C and advanced fibrosis, or MASH with high-risk features who, you know, the question is, should we really be screening in those people? And is there anything we can do to potentially better identify HCC in those slightly higher risk populations? Then I am also going to talk about updates in the treatment of HCC. So the first abstract I'm going to touch on is using liver stiffness measurements as a marker for HCC risk in MASLD patients. So this was a study done in a VA cohort, and they just were looking at those who had had a elastography, a liver stiffness measurement, to see if there was any correlation between the measurement they obtained and risk for HCC. They had the secondary aim to establish different thresholds that could indicate cost-effective HCC surveillance in patients with MASLD who were not cirrhotic. And if we look at the data here, what they did find is in those patients, and you know, the majority of VA patients are male, so this is all male here, but they found that liver stiffness measurements between 10 to 14.9, and those with diabetes, if you used that cutoff, that it did actually have a statistically significant increased risk for HCC. So they found what they concluded is that liver stiffness measurement is associated with an increased risk of HCC, and that a 5 kilopascal increase in stiffness measurement will confirm a 19% increased risk of HCC, and that surveillance potentially could be beneficial in men with MASLD and diabetes who have a liver stiffness measurement between 10 and 14.9, not only those who are cirrhotic. And it is potentially a way that we could personalize HCC surveillance, especially because a lot of these patients with MASLD, we are already getting FibroScans or elastographies on routinely. This is another study, also from a VA cohort, that tried to look at what AFP threshold we should use in screening for HCC. So historically, we use kind of a cutoff of 20, but the question was, is that sensitive and specific enough? Should we potentially change that cutoff? So what they used is a VA cohort. So they had over 28,000 patients with cirrhosis, and they separated them into the cases and the controls. And they looked at patients who were diagnosed with HCC in the calendar year of 2019 and who had had an AFP done within 6 months of that diagnosis. The majority of the people did actually have the AFP done prior to their diagnosis. And what you can see here is that if you use the AFP cutoff of 10 as opposed to 20, it actually does improve the sensitivity of detection of HCC in patients with hepatitis C that's been cured, as well as active alcoholic liver disease, and a little less, but there is some improvement in those who had MASLD. So what they did conclude is that AFP performs better as a screening tool in those with hepatitis C related cirrhosis, and that in patients with cured hepatitis C or alcoholic liver disease, as well as those with MASLD, lowering that threshold of the AFP can actually increase the sensitivity and still maintain a high degree of specificity in the detection of HCC. So something to consider. Okay. Now, there were also a lot of abstracts about genetic risk factors, trying to develop new blood tests to try to, again, help us prognosticate risk for HCC in our cirrhotic patients. This was another VA cohort looking at genetic architectures to try to determine patients who are at higher risk to develop cirrhosis as well as HCC. So they were trying to look at the different interplay between genetic loci and underlying liver diseases. So they did a genome-wide meta-analysis, and they did identify 27 genetic variants that are associated with cirrhosis. And they also found 12 that are associated with HCC. 4 of them were actually novel, which was interesting, and that there was an overlap, and those are shown in yellow here, the 8 of them, which confer risk for both HCC and cirrhosis. And then the question they also had was, well, does the immune system actually have any protection against liver progression, against the progression to cirrhosis or HCC? And they actually did identify some histocompatibility complexes that did confer some degree of protection. So they calculated a genetic risk score, and they wanted to see if this risk score could then be utilized to determine who would progress to cirrhosis or HCC among these cohorts of cirrhotic patients. The majority of their patients were Caucasian. They did have a fair number of Hispanics, as well as African Americans, and of those who progressed to HCC, the risks were higher in the Hispanics of progression to HCC as opposed to Europeans and Africans. What they did note is that metabolic dysfunction, alcohol use, and viral hepatitis actually synergistically interacted with higher genetic risk scores to confer a higher risk for HCC as well as for cirrhosis. This is their graph for HCC. I didn't include the cirrhosis one, but you can see a dramatic increase in risk there. Okay. Now on to another biomarker. So in patients with cured hepatitis C who have cirrhosis, could we have a better biomarker to try to, again, determine HCC risk in this population? So what they were aiming to do is to develop and validate a transcriptome signature to predict that risk. And what they did is they first used tissue samples to try to develop it, and then they validated it in serum. And that's noted there. So they had their derivation cohort, which was the tissue, validated it in that cohort, and then tested it in their serum populations. And so on the tissue derivation, they did have 137 high-risk genes and 33 low-risk genes that they identified. And through the validation cohort and then the optimization cohort, they decreased the numbers of genes incorporated into their score. And if we look at the final score here, they factored out a lot of those different genetic variables. And so they have 3 here, lactoherin osteopontin and anti-leukoproteinase. And they also use their previously defined score of the PL-SEC HCV cure, as well as gender and age. And they found that they were able to differentiate patients who are at higher risk for HCC as opposed to those who are lower risk. Okay. And then there's a different score, which is also looking in patients who have had hepatitis C and who've been cured, who have cirrhosis. And it's a transcriptome-based score, but, sorry. This is this is where we're, sorry. So this is a different score. This was actually not presented at AASLD, but this was published in Gastro just in October. So it is actually interesting and something to note that hopefully we will be able to utilize. But this is a previously validated score that looks at the transcriptome, so the PL-SEC. And what they did is previously they had incorporated AFP to try to increase the sensitivity of this, but they noted that the low risk population who had this score still had an incidence of HCC of about 1.5% per year. So they wanted to see if there was a way to integrate genetic risk factors to decrease that chance of HCC in their low risk population. So it was they started with a single center cohort for their derivation to determine this PAM score. And then they had a statewide multi-center prospective cohort and then a nationwide cohort for which they validated the score. And it's similar, but they were really able to better risk stratify those who are deemed to be higher risk for HCC versus lower risk. And as you can see, the risk of lower risk was decreased from about 1.5% to 0.6 or 0.8%. So it was an improvement over just the PLS score. So the thought here is to hopefully in the future be able to use these scores to then better risk stratify your patients to determine who should actually have more intensive regular screening for HCC as opposed to those who need less intensive screening. I think the big concern here is that a lot of times we all know that we should be screening our patients every 6 months, but the patients don't really follow up, or based on where they live, they don't have easy access to get in for ultrasounds, or they're claustrophobic and don't want their MRIs. So trying to find out other ways of who we really need to push to get HCC screening, and maybe those who don't need as aggressive screening in the future. So trying to make medicine a little more personalized. Okay, now we're going to switch over to treatment. So the first abstract I'm going to talk about is predicting survival among patients with early to intermediate stage HCC. So this is trying to figure a score out to better determine patients' survival. Historically we use the BCLC, and while helpful, it doesn't always incorporate the severity of patients' overall liver function as well as the tumor burden. So in this VA cohort, Goldberg tried to come up with a new model, which they called the Miles score, to better prognosticate. So it was a retrospective cohort study, and they looked at VA patients from 2014 to 2021. And then they tried to predict 1, 3, and 5-year overall survival. And they also looked at the BCLC and the ALB grades. And in this group, they had a little over 1,000 patients. And the variables that they ended up including in their score included age, renal function, INR, sodium, albumin, bilirubin, if the patient had any history of esophageal varices or a history of SBP, the total tumor size, and the alpha fetoprotein. And so it was, what they found is that it was an objective model to predict the overall survival, and they felt that it was actually very helpful in comparison, and it actually improved a little bit better than the BCLC and the ALB grade. So it is something, if validated, potentially, given that a lot of those markers are things that we have, it's a lot of lab results, it's, results from your endoscopy, results from your imaging that hopefully this could help us better determine treatment options for our patients. For example, if you have someone who's deemed very high risk, is it potentially somebody who you should start on immunotherapy earlier, as opposed to somebody who has very low risk and is more more likely to be cured with a resection or would be more likely to be successful with the liver transplantation. Next study we're talking about is the neoadjuvant therapy prior to liver transplant for HCC. So looking at different therapies, whether it be ablation or radiation, and versus chemo embolization. So historically, in patients with HCC who we do deem to be transplant candidates, we oftentimes try to treat the tumors local regionally to control the tumor so that they don't go outside of Milan criteria. And so the aim of this study was really to identify or evaluate the effectiveness of different downstaging modalities and to see which of those actually induce complete tumor necrosis. Because we do know that if you have complete tumor necrosis on explant, it actually confers a better chance of survival long-term. So what they did is they looked actually at the OPTN database and they looked at adult transplant patients between 2012 and 2023 who had an approved MELD exception point for HCC. They had over 10,000 patients and the majority of them had more than one local regional therapy prior to liver transplant. TACE was the most common. I think a lot of times TACE has been chosen first because it was initially what was recommended in our BCLC guidelines. Percutaneous ablation was used in a little under 20%, and then our radiation modalities were less frequently utilized at around 13 or 14%. There actually was a fair number of patients who did have multiple modalities, so combinations of those. And what they noted is that patients who had received the radiation type therapies did have higher rates of complete tumor necrosis, and that those with complete necrosis did have a higher post-transplant survival at 5 years than those without necrosis. So this is something that, in our attempts to treat tumors prior to transplant, we really should try to aim for complete necrosis of the lesions. Okay. So this is the summary, as I mentioned, trying to get complete necrosis for our transplant patients. Okay. So this was a study presented by Tabrizian, and it was looking at the impact of pre-transplant immune checkpoint inhibitors for downstaging. And this is something that has been started, that we're starting to utilize more. There historically has been a big concern about increasing risk for rejection in this patient population. So there has been some apprehension to do so, but it was this multi-center study was trying to look at, is it safe? Can we use it? Is there benefit there? So they were estimating safety and the intention to treat outcomes in this intermediate stage pre-transplant population with HCC. And it was a study conducted at 8 liver transplant centers from 2015 to 2024. And then use a Kaplan-Meier analysis to estimate the intention to treat a multivariable Cox regression to predict outcomes. So they looked at different characteristics among the patients, and overall, the two populations were those who used the immune inhibitors versus those who didn't. Very similar in Child-Pugh score, alpha-fetoproteins, and the number of tumors. In those who were treated, the total tumor diameter in the downstage group was about 6.4 centimeters. And in the immunotherapy group, you have about the same a tumor diameter of about 5.9. The cumulative probability of dropout at 3 years was similar between the different groups. And those who received their checkpoint inhibitors did require a longer median time to successful downstaging, as opposed to those who had other therapies to help downstage them prior to liver transplant. And what they noted is that the liver transplant survival at 3 years for those who received the checkpoint inhibitors was 94%, as opposed to those who had met downstaging criteria via other methods, so 83%. So it does help improve patient outcomes. And then intention to treat survival at 3 years was 72% in that same population. Okay. What they did note is that there were no grade 4 or 5 adverse events related to their immunotherapy while on the wait list, and that about half of them received their last dose of treatment within 1 month of liver transplant. So historically, the thought was, try to prolong the interval between the patient receiving their checkpoint inhibitor and transplant because potentially will increase the risk for rejection if they've received that infusion too close to the time of transplant. They actually only noted that there were 3 patients they found who had rejection, who had been exposed to checkpoint inhibitors. And those patients had a shorter washout period, so anywhere from 22 to 57 days. So a lot of times people will say try to give the patients at least 3 months of a washout prior to doing a liver transplant if possible. Okay. So in conclusion for this study, the post-liver transplant survival at 3 years was 94%. In the patients requiring downstaging due to high risk of dropout, the initiation of immunotherapy may actually be warranted to improve their outcomes. So it's not something to shy away from as we historically thought it was. Okay. This is a study looking at lenvatinib as well as pembrolizumab in combination with TACE or TACE alone. The data was first presented at ESMO in Europe earlier this fall, and then at AASLD, and this was a randomized multicenter double-blinded phase 3 trial. This was their first readout from that trial, and they're using lenvatinib, which is the TKI, as well as pembrolizumab, which is an anti-PD-1 in combination with TACE or just placebo and TACE. And their endpoints were progression-free survival and overall survival. So they were really looking at patients with HCC who were ECOG 0 or 1 and Child-Pugh A, so those who were well compensated. Okay. And at the time of the analysis, the median time from randomization to data cutoff was about 25.6 months. Median progression-free survival was 14.6 months for those who were treated with the combination of lenvatinib, pembrolizumab, and TACE, as opposed to 10 months for the TACE alone cohort. Okay, so overall survival was a little immature, and the significance there was not met. Grade 3 to 5 adverse events occurred in a fair number of patients, but it only led to drug discontinuation in 8.4% and 1.2%. They said not dramatically different from those in the general populations who've received these treatments. And then the last study I just briefly wanted to talk about is an update on the efficacy and safety from I Am Brave. This was actually read out a little bit earlier than AASLD, but I thought important, recurrence rates we know are high in patients with HCC who undergo resection or ablation with curative intent, especially if they have high risk features. So the idea was, can we give these patients atezolizumab and bevacizumab right after that in order to help kind of reduce their risks. And the initial interim analysis had suggested that there was an improved recurrence-free survival as opposed to just doing active surveillance. At that point, the overall survival data was immature. So they looked at an updated analysis. So this was a follow-up at 35.1 months to see if that improvement, that benefit still persisted. And this was their study design. Again, they were looking at patients with HCC who had underwent a procedure for curative intent, oftentimes an ablation or a resection, and they were patients who were well compensated cirrhotics without any high risk features. And then they were randomized to either receive atezolizumab and bevacizumab or just undergo active surveillance. And what they noted on this follow-up was that that benefit of early regression-free survival was not maintained. So a little bit disappointing, but interesting to note. Okay. But when they did another analysis, they did note that among those resection patients, they numerically did a little bit better than those who were outside of the of people with HCC who were outside of the up to 7 criteria. Okay. They did note, however, that there's no different in overall safety trends from the first interim analysis to this interim analysis. So no big differences there, which is good to see. Okay. So in conclusion, what they did note is that it's the first adjuvant immunotherapy-based regimen. It could delay recurrence, but in this follow-up analysis did not really have that sustained benefit as was seen in the first interim analysis. Okay. And that is it. Thank you all.
Okay, so our last speaker of this session is Dr. Jehan Benamou, who's from UCLA and also from the West, well, it used to be called the West LA VA. Now I think it's the Greater LA VA, and she has a research interest in MASLD MASH and HCC, and she's going to talk to us about non-invasive testing for MASH, which obviously is important if we're going to be talking about HCC risk.
Hey, good morning, everybody. I lost my voice a little bit this morning. Hopefully you can hear me. So I will be trying to consolidate what we learned from Dr. Luma's talks this morning by providing real-world case examples of how to use NITs in MASH. I have no financial disclosures. So an outline to today's talk, I'll go over 4 case presentations. These are real-world examples that I've seen at UCLA or the VA. We'll briefly talk about NITs that have been very well covered this morning, and specifically ones that have been pretty well validated and how to apply them in the MASLD patient population. So we'll jump right in. Here we have a 52-year-old postmenopausal woman, overweight with a BMI of 25. She was diagnosed with steatotic liver disease about 4 years ago, incidentally on imaging, and was given a diagnosis of MASLD. Her liver enzymes were slightly elevated. It depends which threshold you use. If you use 20 and below as being normal, this is considered to be slightly elevated. And her FIB-4 was calculated to be low risk, and I provided the thresholds here at the bottom, and we'll talk about negative predictive value for ruling out disease and positive predictive values for ruling in disease. However, her ELF score was not consistent with the FIB-4 and showed possible F2 disease. This led to a FibroScan that was done outside of UCLA and showed F0, so again, consistent with the FIB-4, but not the ELF. And the patient was really concerned, caused a lot of anxiety, decided to come to UCLA for a second opinion. So obviously now coming to a tertiary care facility, getting more testing just because of one lab test that was not consistent with the others. And the MRE at UCLA was consistent with F0. So the patient was reassured. But in this particular case, we think that the ELF score may have overestimated the risk, may be related to her weight, and we'll talk about that. In our second case presentation, we have a 62-year-old male, normal BMI, with risk factors including type 2 diabetes, diagnosed again with MASLD. Liver enzymes, again, slightly elevated in the 30s. His FIB-4 was indeterminate. And unfortunately, this is not uncommon and happens about 30% of the time, which leads to more testing and some anxiety on the patient's part. We obtained a FibroScan. This was at the VA, which showed a low KPA, I guess, if you use 8 as being low risk for advanced fibrosis. So the patient was sort of reassured. And in this particular case, again, FIB-4 not very helpful, which happens in about a third of the cases. So what to do with these patients? This was a very interesting case. We had a 79-year-old gentleman. He had a history of stricture and Crohn's disease. He was obese with a BMI of 35 and had cardiometabolic risk factors, including hypertension, coronary artery disease, and was diagnosed with steatotic liver disease. Based on his alcohol consumption using the ASLD guidance, we diagnosed him with mid-ALD. His liver enzymes, unlike our first 2 cases, were completely normal. So this was really over years. This was not at one point in time. Platelets were in the 300s. Synthetic liver function tests were completely intact. So, you know, a lot of risk factors, but everything looked okay in terms of his laboratory testing. His FIB-4 was low risk, and patients over the age of 65, and we'll talk about age as a confounder here, should have a different threshold, right? We usually talk about 1.3, and Dr. Lumba said, remember 1.3, but I think anybody over the age of 65, there's some recommendations that basically recommend using 2, given that age is a huge component in the equation of the FIB-4. So we follow that up with a FibroScan, which showed F2 to F3. So again, patient with a lot of high risk factors, normal labs, low FIB-4, but now possible some fibrosis on FibroScan, and could be potentially overestimated considering the BMI of 35. This was followed that up with an MRE, which now showed cirrhosis, right? So a lot of silver all over the place. We had a conversation with the patient and said, you know, you have a lot of risk factors. Some things don't match. We could do a liver biopsy, which he wanted to do. And the liver biopsy confirmed steatohepatitis with stage 4 fibrosis. So here, MRE, way to go, usually a really good test, especially in that BMI cutoff, but the ALT is normal. So this is another really important take-home message is if the ALT is abnormal, it can be helpful. However, you can have normal ALTs. This occurs about a quarter of the cases and sometimes higher, even in patients with diabetes, up to 50% of the case in one study. This is our last presentation, a 46-year-old premenopausal woman, and I make the distinction between pre and post because we know that postmenopausal women are at higher risk for liver disease progression. NITs don't necessarily sort of differentiate between that, but may in the future. Also had risk factors with type 2 diabetes, dyslipidemia, and was presumably had MASH, or was given a diagnosis of MASH. So in 2023, her BMI was 30, ALT was elevated at 77, her FIB-4 was low, and FibroScan stage 2 to 3, right? So young patient, you want to be very aggressive, right? This is pre-resmetirom days, what to do with this patient. We had a long conversation, and actually the FibroScan served really as a huge motivator in this patient, which is not uncommon, and implemented pretty strict lifestyle modifications, weight loss. And in 2024, that should say, her BMI did drop to 25. ALT, as you can see, significantly improved. FIB-4 still remained low, but the FibroScan this time showed a decrease to F0. So did she really go from F2 to F3 to F0 in a year and a half, right? Was there an overestimation because of active steatohepatitis, potentially based on the elevated liver enzymes? Another important point, and I think this happens a lot in clinical practice, is we talk about these tests sort of as a one-time point, but I think we should really be using them sort of longitudinally, and it can be very helpful in monitoring these patients independently of the treatment modality. So what does the FDA have to say about NITs? This is a statement that was published in 2023, where the FDA supports the use of NITs in patients with MASH in two cases. One is in early drug development, so phase 1, phase 2A trials, and this is really to potentially use them as biomarkers for treatment and also to identify high-risk patients. The other instance is in phase 2 trials and mostly to identify at-risk patients who we would want a biopsy to enroll into our trials. So the reason why this is important is because a lot of these NITs have been really validated in high-risk patient populations who already have a high pretest probability for having steatohepatitis and advanced fibrosis. And these tests should probably not be used in the general population where the risk factors are lower. So again, trials are great, but what about the real world? How accurate are these tests at different stages of fibrosis? What are the patient and the non-patient related factors for NITs? And then how do we use them for management? So I want you to keep those 4 cases in mind as examples as we go through the rest of the slides. So can be a little bit of an alphabet soup, but I think these are important terms. I've provided these mostly for your reference. When we talk about ruling in and ruling out disease, we really tend to focus on the positive and the negative predictive values. So if you want to rule in advanced fibrosis, you look at PPV, which is positive predictive value, and the probability that a person with a positive test actually has the disease, and a negative predictive value where the person with a negative test really does not have it. So I think everyone in this room is sort of familiar with the change in nomenclature, but just to make sure we're all on the same page, this was recently changed by the 2023 AASLD guidance, where steatotic liver disease really starts by identifying cardiometabolic risk factors, which are listed here. If the patient meets these criteria, assuming they don't have any other competing etiologies, they have MASLD. If there is a large component of alcohol, which is not uncommon, then it's a MET ALD diagnosis. If they don't have any risk factors, but they're still steatotic liver disease, usually found incidentally on imaging, they can fall into either the cryptogenic SLD, or it's another more rare etiology from DILI, monogenic mutations, or they're just not being very forthcoming about their alcohol intake. So again, thinking about these NITs and using them in the right patient population, type 2 diabetes is probably the most important risk factor in this disease. And as shown here in a recent publication, MASLD in the type 2 diabetes patient population is rising quite significantly. So now up to 70% of patients with type 2 diabetes will have fatty liver. And I think this is a really important slide because we like to put everybody in the same bucket, but this is actually a very heterogeneous disease. And you can think of environmental factors, including social determinants of health that fall into that, metabolic risk factors and genetic risk score, which Dr. Lumba discussed a little bit earlier. And really, you'll have different patients fall into different categories, and these NITs may be more helpful in certain populations than others, and it does affect where in the spectrum they fall. So this was shown earlier this morning. The reason why we care about NITs and fibrosis staging is because they can help us identify liver-related mortality and all-cause mortality, which is shown here to increase starting at stage 2 and above based on the Medivir scoring system. And we'll start delving into some of these NITs. So the most commonly used one is the FIB-4. We'll talk about ALT. There's also the NAFLD fibrosis score, an APRI, which does not include age. And for the purposes of today's talk, we'll focus on these two. So FIB-4, as was shown earlier, is the equation shown there for you guys to see, but the age is a huge factor, right? So the negative predictive value is quite high at 1.3, is much lower as you go up, and the positive predictive value is over 90% once you reach 2.67. The one caveat, there's two caveats. One is age in this equation. The second one is ALT. So as discussed in our previous case with the patient with biopsy-proven cirrhosis, you can have normal ALT, and it could be that the patient had cirrhosis and there's no active steatohepatitis, or it could be that they just have a normal ALT, right? So if it's positive, it's helpful. If it's not, it doesn't rule out disease. And this was a nice study showing how age is a huge contributor to this equation. This was published from Japan, over 75,000 patients who had abdominal ultrasounds at checkup. And you can see that the majority of patients, if you look at FIB-4 on the x-axis, who are less than 50 kind of fall in the low risk population. But as the age increases, you can see that the majority of patients over the age of 70 fall into the high risk group. This was a really nice study published by Dr. Kaplan's group at the VA with the idea that perhaps looking at FIB-4 longitudinally makes more sense. So here they developed a model looking at the FIB-4 slope. And this was done in the VA with a 20-year follow-up period, as you can see here, and they used a threshold of 0.082. So patients who had a high or persistently high slope over 0.082 in the solid line were at much higher risk for developing complications of cirrhosis, HCC, and liver-related complications over a 20-year period. This was another study from the VA looking at the post-SVR patient population, but a lot of these patients had steatosis by FibroScan. And you can see that if you use baseline FIB-4, which is shown here on the right-hand side, you can stratify patients by in different categories. So anybody who had a low FIB-4, less likely to develop HCC over time. Those with a high FIB-4, more likely to develop liver cancer, which makes sense. If you look at the FibroScan data in the same patient population on the left-hand side, also correlates with FIB-4. So anybody over the KPA of 25 and above were much more likely to develop cancer over time. So this was a study that I think Dr. Lumba also alluded to earlier, where using a longitudinal FIB-4, it can be very helpful. So in this particular study, Dr. Conwell's group categorized veterans into 3 categories, so low risk, intermediate risk, and high risk. And then they looked at what happens to these patients in terms of HCC risk if they switched categories. So patients who started out as high risk and remain in the high risk category in the dashed gray line had a 50-fold increased risk of developing HCC over time compared to those who started out in the low risk and remain in the low risk category. So this makes sense, right? Risk factors are dynamic. We talk about these NITs sort of like at one point in time, but as risk changes over time, especially with new therapies coming along, I think it's important to reclassify patients and look at longitudinal data. So FIT4, great test, many caveats. Age is a big one. It's been validated in patients between the ages of 35 and 65. So the threshold does change over the age of 65. Remember that ALT can be normal. The onus is on us to rule out other etiologies for abnormal liver enzymes. And it's probably not a good test to use in the general population when the pretest probability of having MASH is much lower. So what about ALT? We've talked about ALT this morning. I think ALT can be helpful if it's abnormal, right? If it's not an abnormal ALT, you can't really follow it. So this is data from the obeticholic acid trial looking at predictors of histological response over time. So the odds ratio are presented on the x-axis and highlighted in the red box. You can see that if a patient had an abnormal ALT at the start of the trial, if there was a decrease in ALT at 24 weeks by at least 17 units, that this was a predictor for histological response. So makes sense, right? So if it's positive, helpful. If it's not, can't rely on it. So what about direct serum biomarkers? These measure fibrosis in the blood or can be proxies for fibrosis. So we have the ELF score, the FibroSpec NASH, the FIB-C3, and we'll focus on the ELF. So similarly to the FIB-4, you can look at positive predictive value, negative predictive value, and identify thresholds that would rule in or rule out advanced fibrosis. On the right-hand side, this was data presented earlier. You can see that based on the Medivir scoring system, the ELF score does go up. The one caveat is that there's huge overlap between 3 and 4, as you can see here, so it may not be great at differentiating between the two. But ELF can be helpful in predicting outcomes. So this is data from the phase 2b simtuzumab trial, which was a failed trial. But if you looked at longitudinally what happened to the patients who had biopsy-proven MASH with an elevated or a low FIB-4, you can see that those who had elevated FIB-4 are more likely to develop complications of cirrhosis over time. So limitations of ELF, it's a good test because it's a direct marker, sort of what's going on in terms of collagen deposition and fibrosis, but it can be affected by weight. So this is important, especially as we're talking about GLP-1 analogs and weight loss as being part of the management of these patients. And again, I think looking at trends is probably more helpful in these cases. So we'll talk about elastography. Briefly, again, this was presented earlier. We know that KPA correlates to outcomes. This is looking at enhanced data based on different KPA thresholds, and the higher the KPA, here being 20 in the purple line, the more likely patients will have lower survival related to liver disease. And similar data are found by CAP score thresholds. MRI, PDFF, MRE is probably one of the best tests that we have. If it is available in your facility, it's not the cheapest test. Not everybody has access to this. But as shown here for your reference, pretty high negative predictive value and pretty good positive predictive values. And the KPA in MRE does correlate also with outcomes as shown here. But it's important to remember that the KPA in a FibroScan and the KPA in MRE are completely different. So you cannot use one for the other interchangeably. Different tests. So I've provided this mostly for your reference. I won't go through it, but this summarizes data for FIB-4, ELF, FibroScan, and MRE, different thresholds depending on these, whether you're trying to rule out advanced fibrosis or rule in advanced fibrosis. So there's been a lot of guidance about how to use these tests. As we learned this morning, the FIB-4 is sort of the first test that we recommend. It's cheap, it's available. It's not a send out like an ELF test, for instance. But the point here, and these are guidelines from the AASLD, AG, and the American Association of Clinical Endocrinology, is that you have to identify high-risk patients. So those with type 2 diabetes, one or more cardiometabolic risk factors, and the pretest probability and how you apply the test matters, right? So you should interpret the test in the right patient and make sure you're ruling out other etiologies. So depending on where you fall in the FIB-4, there should be a sequential non-invasive test that follows that up. either FibroScan, MRE, ELF if it's available, to try to risk stratify the patients. These are AASLD guidance, which I won't spend too much time on as you're familiar with these, but the point I wanted to make here is that, again, the first test is the FIB-4, whether grade or not. This is what sort of everyone is recommending to start with. And these are different guidance that were published in Gastroenterology last year, where the difference here is that they recommend either using a FIB-4 or an ELF test to start with. Again, ELF is not available everywhere, and there is a cost associated with that. So different thresholds in different patient populations. I thought this was an important study to mention, published by Dr. Tenkopa and Dr. Lumba's group. What they did here is they looked at 244 adults with biopsy-proven fatty liver disease, and about a third of those patients had MASLD. And if you look at the area under the operating curve for different types of NITs, so either for significant fibrosis risk or at-risk MASH, and here they looked at MRE, FibroScan, FAST, MAST, or MEFIB, which was a new one for me. But the point here is that patients who self-identify as Hispanics actually had a lower threshold compared to other non-Hispanic individuals. So this is important because if we think based on genetic markers, and we'll talk about that, and other risk factors, that Hispanic individuals are at higher risk, then perhaps 1.3 should not be the threshold that we should be using to identify or at least rule out disease. So I think the idea that, in precision hepatology, and going back to the idea that MASH is very heterogeneous, and I think we should try to understand how these NITs work in different patient population is important. So what are the factors that impact performance in NITs? You can think of them as sort of in 4 different categories. One is patient-related. So for instance, we know that congestive heart failure, you cannot use FibroScan or MRE, right? So we usually rely on biopsy, which is also not perfect, but congestion can clearly overestimate any increase in blood flow. This is why patients also have to fast when we do these FibroScans. If there is active inflammation, which may have happened in our third case that we presented, and the liver enzymes are elevated, you can also get an overestimation of the KPA. So interpreting the test in the right context with the right lab values is important. Metabolic syndrome, so BMI threshold, right? I use a BMI of 35 and above. If I have a patient who comes in for risk stratification, I'll go straight to MRE. I will not do the FibroScan unless there's a contraindication to MRE. This may not be available to everyone, but understanding that BMI can affect the accuracy of the test. Age, we talked about. Race and ethnicity are potential confounders now in how we interpret these tests. And then also the prevalence, right? You have to apply these in the right patient population. And what are the risk factors? And this includes genetic testing. So I'll end here. This was a study, mostly sort of proof of concept, and also one, at least that made me think a lot. Published by Chen et al. And here they're proposing to incorporate PNLPA3 genotype in the algorithm to identify at-risk patients. So they first use the FIB-4, like most guidelines. If the FIB-4 is low, the patient is considered to be low risk. If the patient is high risk, then great, this is high risk. If the patient is in an indeterminate risk category, which remember can be about 30% of cases, then the risk stratification using genetic testing could be helpful. And this depends on whether or not they have diabetes. And what they show here is that in the diabetic patient population in the indeterminate risk for FIB-4, perhaps PNLPA3 can sort of differentiate between high risk and lower risk patient. So I'm hoping this comes up in the panel discussion. Are people thinking about PNLPA3 testing? Who is paying for it? How do you use it, clinically? I think this is coming up in the abstracts also that Dr. Lumba presented. So to summarize, NITs are here to stay. About 30% of the patient population has fatty liver, so we really have to really understand how to use these tests appropriately to help us in clinical management. And understanding their limitations is one way we can do that. Understanding that these tests could be dynamic as risk factors change over time, and using the data longitudinally perhaps makes more sense than at one point in time. And I think not stopping at one NIT, but using sequential testing is important. And then again, the idea of precision hepatology, how to use NITs in different at-risk patient population may become important over time. With that, I'll end. Thank you.
So I want to invite all the speakers who were speaking this morning, as well as Heather Patton, who's from UCSD and the San Diego VA, to come up for a hopefully vibrant panel discussion. Right. Go ahead.
Good morning. I've two regulatory questions. First for Dr. Lumba and then for Dr. Hirschfield. Dr. Lumba, next July, presumably end of second quarter, we're going to have semaglutide approved for NASH, probably in the United States, somewhere around that time. So F2, F3, same indication for as Rezdiffra right now. So how does a practitioner decide which drug to use? Number one, and number two, there's going to be, we would like to know if we could use both drugs together in the semaglutide dose that it's going to be approved for NASH, because that's not been studied yet. So how do we figure that out? Who's going to pay for that study?
Yeah, I think. Thanks, Paul. I think what will happen is we as community would start doing these experiments, as some people are already experimenting, resmetirom and cirrhosis, as I mentioned. I think that that's what will likely happen in our own practices, and I think we will develop real-world data. My gut feeling is that there will be an updated guidance from ASLD, but will be lacking probably by a year. So there will be expert panel sort of guidance coming out, around the same time it'll get approved, to think about, patients who are maybe significantly overweight, obese, and have type 2 diabetes, and that's uncontrolled. Potentially you'll start with, one line of therapy in terms of initiation. Those who are already on it, the thing is, I think about 30% of the patients that are referred to us have previous GLP-1 exposure. But you make a good point that they could be, on a suboptimal GLP, and then, or they may be on a lower dose of 1 milligram for type 2 diabetes. And so I think those patients probably will not change, and they'll stay on their original GLP, and then we'll probably add resmetirom. Other thing that could happen is, President Biden just suggested, there was a press release about, making GLP analogs available for treatment of obesity. And if that happens, then that can have a major impact on policy. I don't know how they'll fly with the changes in the government, so that may not happen. So I think a lot of will depend on policy as well.
My second regulatory question is for Dr. Hirschfield. Thank you, Gideon, I'm surprised you were willing to leave Toronto in December and come to San Diego. We greatly thank you for doing that. So as you know, obeticholic acid was not approved by the FDA advisory committee meeting held this year, and the Intercept received a complete response letter from the FDA saying that your COBALT trial was not adequate and the drug's not approved. So that leaves us in kind of a no man's land for the subsequent drugs for PBC. It also raises a question for the two drugs that are going to go into phase 3 trials for PSC, which is, can you use liver transplant, decompensation, death as primary endpoints for these studies in the Western world, where we have the option to take people off the studies. It's not in the patient's best interest to stay in placebo arm. You're functionally unblinded with both PBC and PSC. Those patients know if they're getting worse. So how do we convince the FDA, the regulatory committees, well, in Canada, you have a different one, but let us do this?
They're great questions. I mean, I think on the pathway to better treatments, we're on that journey. And some of these things will be solved by when we get even better drugs. Okay. And as the drugs get even more efficacious, then the difference between risk and benefit becomes much clearer. And that's definitely a good starting point. The next point is that, the opportunity to use even better real world data is coming. And I think that, as everyone's using electronic medical records more and those tools to actually track what's happening to our patients in the community get better, so our real world data quality is going to go up. And the way I see it then is, as real world data quality goes up and as drug efficacy also improves, then I think the agency will move into a position, and certainly for PBC, where, the comfort zone becomes better, that they have to change their approach, because there is no way to, when you've got multiple drugs on the market, for all of them to do an endpoint study based around clinical benefit. There aren't enough patients, and the patients won't take part, and they won't stay on placebo, as you pointed out. And then, more to the point, what liver drug, and even the hep C drugs struggle, works best if you wait until the very end of liver disease to start doing the clinical trial, so that you weight it towards clinical endpoints, when in fact you want to treat them much, much earlier than that, which is 20 years prior. And even in NASH, you're going to face this problem where clearly you want to treat them long before they're approaching their endpoints. So that's how I think the field will evolve. PSC is even more complicated by the fact that the FDA gave a clear steer that they believe phase 3 clinical trials should be endpoint driven, clinical endpoint. And that's incredibly difficult, because PSC is so variable. We can't define cholangitis. We don't even know what is meaningful cholangitis. What is, cholangitis you just treat by sending an EPIC prescription for Cipro without seeing the patient, because the patient knows their disease so well. Again, I hope what will happen is we'll get to the point where we can see it in NASH, where we have enough data on ELF and FibroScan to use those more meaningfully. But it's not going to solve itself as quickly as we like.
Hey, Brian.
Thank you. Hi, Brian Lee from Hoag. I have two questions. The first one's quite bloated, and hopefully it'll just provide some discussion. Stephen Harrison published a very nice review article earlier this year on liver biopsy. And in our MASH trials, we have such high screen failure rates, primarily because of very strict histologic screening criteria. And I guess my question is, in the real world, I'm primarily a clinician. When I mention the words liver biopsy to my patient, it's like I have horns coming out of my head all of a sudden in the shape of biopsy needles. So I was a little bit curious how that plays out with some of our therapeutics in real world data. I'm prescribing resmetirom, but not biopsying every patient. How does that play out? And just curious to hear what the panel thinks.
I think, Brian, you're doing exactly the right thing. We started looking into that 15 years ago because to me, it didn't make any sense to be doing liver biopsies when patients didn't want it. We just didn't have enough tools. And so I think I can say that over the last 15 years, we have better tools to assess. They're never perfect. We also know that liver biopsy is not perfect. But to that end, I do still believe that liver biopsy assessment gives us a reasonable way of assessing drugs over 1 year. And I think that is clear, because then at least you can get a subpart H and get the drug to the market. And I agree that we shouldn't be doing liver biopsy for assessing who needs to be treated with resmetirom in future, who needs to be treated with semaglutide, because we are capturing all this NIT data in all these trials. And that's why I was showing you. And then the next question comes assessment of response. And I agree with you that I won't be doing, if my patients are improving, I won't be repeating a biopsy to document a response unless somebody really wanted to get off therapy and say, I have no fibrosis or, a significant regression by 2 or 3 stages after 5 or 6 years or 7 years. So I completely agree. We don't need it. And I think we can utilize our currently available NITs. They are reasonably good. And to Gideon's point, we're moving the field. So in 5 years, even our trials for surrogate endpoint will replace the biopsy if that becomes more efficient. And so we are coming up with a concept of RLSC, reasonably likely surrogate endpoint. And this will be completely non-invasive and will replace the biopsy if needed. But to me, we could do a 1-year biopsy trial and get a drug or 72-week and show convincingly that drugs are working. So that's why we're using it currently. But we have another big phase 3 program that will come in the next few months to years where there will be a complete NIT-based trial from the get-go to long-term and RLSC in between.
Can I ask a quick question, Rohit? Have you reanalyzed any of your phase 3 data to look at placebo response if you actually looked at the data as if it was an NIT study? Because one of your biggest challenges is that you've got a very high placebo response in all the NASH data, and the semaglutide placebo response, is very intriguing. But have you actually looked at, is the placebo response lower if you're looking at, say, if you just reanalyze it around ELF?
The placebo responses are variable depending on the precision estimate of the entity that you're using. And so sometimes the placebo response is real. For example, PDFF responses are real. But there are, I think if you, I didn't show one slide, but we looked at totality of data. So which means patient met all 3 responses. And if you conclude that, then you hardly see placebo response. It's 0. So if you wanted a PDFF response, a ALT response, and an ELF response, you don't get that with placebo. But what happens is that, why don't we just use that? The problem is then a very small fraction of patients actually achieve all 3. But I think we can impute it by various algorithms. That's where I think field of drug selection will go, where we'll have AI-based algorithms where we will screen various drugs and say which one should move forward. Because the next thing will come up is we already have resmetirom, we already have sema, we have tirzepatide coming. If we were to develop newer drugs, they have to be better than them or have no side effects or different side effects. And so we may screen out drugs, even if they work, either they have to be substantially cheaper to move them forward. We may actually get rid of them earlier. So I think the NIT is the future, and biopsy will only be in the cases where we think that they've got autoimmune problems, some other problem that's happening.
I just want to add that I think getting real world data is going to be incredibly helpful to understanding how these NITs sort of perform outside of the context of the clinical trial, and helping us do a better job identifying patients without a biopsy. I practice within the VA healthcare system, and resmetirom criteria for use to prescribe within VA is requiring a liver biopsy, which created a whole lot of angst amongst those of us taking care of patients with MASLD in the VA healthcare system. But what we have done is to go to the National Pharmacy Program and request that we're really prospectively gathering information about patients who qualify with biopsy, their NITs within our healthcare system to hopefully help inform as more drugs are coming online, that we have our own internal data to say these criteria really identify patients who are going to qualify for treatment without a biopsy.
Yeah, you bring up a great point, Heather, and I guess that alludes to my second question, which is, and Rohit, you were mentioning earlier, the Essence trial that Novo Nordisk published. You mentioned sort of this change of treatment dropout sort of becoming or imputed into the placebo arm. And I guess until we see NITs really pushed out into trials and hopefully FDA adoption, is that sort of the new trend we're seeing with placebo imputation in order to at least show some efficacy of the actual drug in the treatment arm?
Yeah, I think you'll see a lot of trials published in New England Journal of Medicine. The reason for doing these is, it comes from oncology where you have patients dropping out, particularly in long-term trials. So if you have a trial going 5 years, so what do you do with that? I think the reality is I think semaglutide works. If we only had the trial with 300 patients, 2 treatment arms, and then placebo, it would be marginal, in terms of, but the way it was structured, this is the largest phase 3 with subpart H assessment that has ever been done. And it has double the power of most previous studies. And so I think they're able to show it. Nothing wrong with it. I think that's what they should have done. Predominantly stage 3 fibrosis. So, to Paul's point earlier, one could initially think, oh, well, semaglutide could be used in early disease. As you go to stage 3, you don't need sema. But here they have evidence now, 70% of those 550 patients had stage 3 fibrosis, and they also improved. We don't have data on 2 stages improvement. A lot of data is not there. I think it's still reasonable to say that the drug does work. They did say, when I asked them the question at ASLD, that what is the ITT and is significant? The response was that it is significant, but it was not shown. So the paper should be out, and hopefully we can do a deeper dive into that data. I think we will continue to see that, because now the other drugs that are coming are going to be GLP plus glucagon agonists. The dropout rate is going to be even higher in those, about 20%. And so those drugs will need to be assessed with the EDP assessment. So we're going to see more and more of these in future.
Are these dropout rates related to the fact that they have to get a sequential biopsy, or is it more so just treatment related?
Side effects. I think the biggest is the side effects related to these drugs. Many patients are not able to tolerate it. And I think that's real life also, to Heather's point. They say up to 50% of patients may not be on a GLP-1 analog 1 to 2 years after starting. Now, this is a different question. I don't think this is all side effect related. It is also related to access, because many patients, their insurance is not approving that, future sort of continuation, and they may require additional things. So that may happen to us also, that, we may start with a bang of 2.4 milligrams sema, and then something happens and then it's not available. And we go down to say, you can use GLP for diabetes. That's much cheaper. So the cost will also be, coming into factor.
Thank you.
Okay, Wally.
Walid Ayub from Cedars. Practical question for Jihan. So we have an aging population now, a lot of people over age of 65. Now, the FIB4 is recommended by the guideline to screen the population. So what would you recommend doing for this age group? Using FIB4 greater than 2, you still have decent negative predictive value, but not perfect. Would you move to a FibroScan or to a combination fast mass like Dr. Lumba presented a couple of years ago?
Yes, I would. So I think changing, excuse me, the FIB4 already helps. As you mentioned, it's still a large patient population. I don't always just trust the FIB4, I'll be honest, maybe because I'm a hepatologist and I can do FibroScan and MRE easily at the VA. But I always follow that up with another non-invasive test. We don't have the ELF score easily accessible, so we don't have as much data for that. And I think just following the patient, but also scientifically, the idea that aging, right, is liver disease an aging disease. I think people are still trying to figure that out also, which is also very interesting. But that's personally what I would do, is just change the threshold and not stop at one test, but do multiple
I
NITs.
fear by using the current FIB4, 1.3 or less.
Oh, yeah. I mean, over the age of 65, there are data to support that we should be using 2 and below. As you saw in our example, right? And in fact, what I didn't say about that case was that the patient was supposed to get an MR enterography and accidentally got an MR elastography because the tech didn't do the right test. And it showed F4. And that's how the patient ended up in our clinic. And that's what we followed up with a biopsy. That just reminded me that how many patients with cirrhosis are walking around that we just don't know about too, right? So the NIT solves some of that problem, but certainly not all.
And one more question to Gideon. Now we have two new drugs for PBC. So what are you doing with your incomplete responder to obicolic acid? Are you switching or adding?
Well, I think that's a great question. I mean, I think the way I would tackle that would be to look at their symptom burden. So and also to see how close they are to your treatment target. So if someone is itchy on OCA, then I think you're going to switch to a PPAR. Okay. If someone is young but has had a reasonable response to OCA and they say they've gone from 300 to 200, I think you're going to add. Okay. Now, whether or not you're going to get reimbursement, I think that's going to be state by state. I think that's something that you're all trying to feel your way through. But that's essentially what we're doing in Canada, where we use OCA first line because it's approved, and then we add in bezafibrate based on how close I think I should get to my normalization target. We're using the other thing we're doing is if we can't get OCA reimbursed, that's when we're giving the PPARs in Canada to bezafibrate, because particularly in our younger patients, we recognize that they really need to get to normal, and an ELK phos of 180 in a 50-year-old is not good enough. Okay, an ELK phos of 180 in a 75-year-old, you might say you've done all right. So I think you're going to individualize around symptoms, around ELK phos and the delta that they had on treatment, and around that individualized risk assessment of how close do you have to get to intuition.
Thank you.
I think we have time for one last question.
Okay. What is the incidence of a hepatocellular carcinoma in PBC? Should they be screened like a chronic hepatitis B patient?
Great question. So there's not much literature, actually. There's a paper that we wrote on it. I would say that we're seeing less and less HCC in PBC. I would say that traditionally the patients who are getting HCC and PBC were the very advanced cirrhotics and maybe the men with F3 and non-response. And so our current practice is that certainly in a man with cirrhosis, we'll screen every 6 months for HCC. In a woman, we'd probably look at their FibroScan and their ELK phos response, because I think then the true benefit of screening is not quite there. I mean, definitely when we published on it, I'd say that for PBC, it's probably a 1% chance per year if you're a cirrhotic to get HCC, whereas for Hep B, it's probably closer to 3. So it's a good question, but it's still, in reality, fortunately, a rare event. Where it's really hard is the cofactor MASLD. That, I think, is going to change some of the sort of thinking. Then I think, my threshold for doing a surveillance is lowered, because if they've got MASLD and PBC, then I think you're probably going to err to some of the talks you heard about the thresholds for screening.
I asked that question because recently I found a very well-controlled PBC patient, male patient, developing hepatocellular carcinoma.
And I think that, and I totally agree. And that's why men, I think, which represent probably only 5% of your population of PBC, historically have been suggested to have a higher rate of HCC, but they have a higher rate of HCC across all liver disease, which is presumably something to do with the sex hormones changes. So the men always worry me. You're right.
Okay. Thank you.
We're going to resume. My name is Paul Pockris. I'm one of the co-moderators, and I'm taking over for the rest of the morning. And we're going to try to stay on time. So our first speaker today is Juan Pablo Frias, Pablo has spoken for us a number of times before. He gives a great talk on incretin-based therapies for metabolic disease. He's an endocrinologist, not a hepatologist, but it gives us a really good view of what other physicians are thinking about when they're treating metabolic diseases. And he's been doing this a lot longer than we have. So he's currently Chief Medical Officer and the head of diabetes at Biomea Fusion. But he's worked as a principal investigator. His name is on a lot of the studies that have studied NASH drugs over the years. So Juan Pablo, thank you.
Hey, thanks, Paul. Really appreciate the invitation. I'm really nice to be back in this area from the Bay Area. I actually get a little PTSD when I'm here because I was stationed at Camp Pendleton as a Navy physician with the Marines like 4 decades ago, I think. But I did do my fellowship in San Diego in endocrinology. And over the years, probably 35 years or so, I've had academic positions in industry, and then most recently ran a clinical research center in Los Angeles for about 12 years or so before we sold the centers. And we did a ton of work with incretin-based therapies over those years. And I was very fortunate, actually, because coming out of fellowship or shortly after fellowship, I spent some time in Indianapolis at Eli Lilly, and we were working on some very early phase GLP-1 receptor agonists at that point. And then I was at Salix Pharmaceuticals, which is in San Diego. In Amylin at that time, this was in the early like 2000-ish or so, we developed actually the first GLP-1 receptor agonist that came to market, which was exenatide twice daily, or Byetta, and that was in 2005, and also the first amylin analog, and that, which is pramlintide, which is still on the market. It marketed as Similan, which is an amylin analog that basically is given 3 times daily as an injection. So as you can imagine, it's not terribly popular. But as I'll show now, Novo Nordisk and many other companies now have long-acting amylin analogs, which are extremely effective in weight reduction. So I've been very fortunate to be sort of in this field, if you will, for a long time, and also practicing and using a lot of these medications, which has been really nice to study them sort of from the beginning and then actually be administering to patients. So here are my disclosures. And these cardiorenal metabolic diseases, I mean, extremely common, as you know, increasing in prevalence, and very important because they've got such important implications with respect to morbidity and mortality for us, first of all, to prevent them if we can, but certainly to treat them appropriately. And really at the core of all of this is insulin resistance. And the majority of these patients, whether they have type 2 diabetes, heart failure, metabolic liver disease, are generally overweight and obese. And really, we were very siloed. You know, when I first started as an endocrinologist, we actually only had 2 classes of medications, sulfonylureas and insulin. So the cutting edge diabetology was adding NPH insulin to glyburide, like woo. And now we've got 12 classes of agents. We're mixing them together, and it's really become quite different. But we were very sort of focused on very glucocentric, so on getting the glucose down and preventing microvascular disease. But clearly, over the years, we've reached out, as hepatologists have, towards diabetes as well, realizing that these are just, a complex of disorders with, again, insulin resistance as a core defect. And now we have drugs that can treat these. And metabolic liver disease is a critical component of all of this. And as endocrinologists, we certainly need to be more aware of this because we see so many of these patients in the front line. And not only is MASLD more common in people with diabetes and with obesity, but it's also more progressive, and these patients tend to have more aggressive disease. And the GLP-1 receptor agonists, through weight loss, through reducing and improving inflammation, through improving glucose homeostasis, really have an effect. Or we've seen, this has been a year of many trials, as Rohit mentioned in his earlier talks, looking at the effects of these GLP-1 receptor agonists or dual agonists in patients with metabolic liver disease, but clearly defatting the liver, improving steatohepatitis, and probably improving fibrosis, more to be seen with that, and long-term liver-related outcomes, but certainly improving cardiovascular risk, which is such an important component and really the reason, unless a patient has decompensated liver disease, the main cause of death in these patients. So the GLP-1 receptor agonists, we have very good evidence, certainly in the middle there for type 2 diabetes with the first GLP-1 receptor agonist, as I mentioned, exenatide twice daily, approved over or around 20 years ago For obesity, the first GLP-1 receptor, the agonist that was approved was liraglutide, so a once daily injection at high dose. That's Saxenda, so been around for a while. And I think every time, every month I open the New England Journal to see a new study about semaglutide improving something. But we've seen that the selective GLP-1 receptor agonists improve major adverse cardiovascular events, cardiovascular death, improve heart failure, diabetic kidney disease, stroke, and then more investigational and related to this talk. On your left is metabolic liver disease and importantly some CNS diseases as well. But we'll focus obviously on the metabolic liver disease here. And the effects of these agents really go beyond just the effects on dysglycemia and on body weight, but really are felt to be due to improvements in inflammation. And if you look at the top left corner, these may be direct. So activation, GLP-1 receptors activated on T cells, and certainly indirect effects of improving inflammation through improved weight loss. And this comes through reduced appetite and improved satiety through central signaling. And very important with respect to metabolic liver disease. So we feel, and certainly in sort of regression analyses that have been done in studies looking at improvement of steatosis and inflammation in the liver, that the effect is beyond just the effect on weight loss, but there's probably something else, and it's probably this improvement in inflammation. So let me talk now, just to put this into context, about the two incretin hormones, so GIP and GLP-1, and then also glucagon. So GLP-1 has effects at the level of the pancreatic islet to enhance nutrient-stimulated insulin secretion. It also reduces glucagon, and this is what you want after a meal: high glucose, high insulin, and low glucagon. Binding centrally, you get a reduction in appetite, and this is what leads to weight loss when given pharmacologically. And there's some delayed gastric emptying, but there's generally a tachyphylaxis to this with the long-acting GLP-1 receptor agonist. And examples of these are semaglutide, so Ozempic, and dulaglutide, which is Trulicity. And Ozempic or semaglutide is the most potent of the selective GLP-1 receptor agonists with respect to body weight reduction and glycemic control. So in comes GIP, the second incretin hormone, and this augments even further this nutrient-stimulated insulin secretion. Interestingly, you actually get an increase in glucagon, although when you combine these with a drug like tirzepatide, the GLP-1 component really takes over, and we actually see a small reduction in glucagon. But at the level of the CNS, even greater reduction in appetite when combined with GLP-1. They're separate receptors in similar areas of the central nervous system. But very importantly, there are no GLP-1 receptors on adipocytes, but GIP receptors are highly expressed on adipocytes. And the thinking is one of the reasons the dual agonists, as I'll show, may be more potent than the selective agonists like semaglutide, is that by agonizing the GIP receptor at the level of the adipocyte, you get an increase in the so-called buffering capacity of the adipocyte. So the uptake of triglycerides postprandially, more appropriate release of free fatty acids in the post-absorptive state. So basically a healthier adipocyte, which reduces ectopic accumulation of fat in the liver, in the heart, in the kidney, in the islet. I mean, today there's like fatty everything, but it does improve, as you'll see, and as you know, the steatosis in the liver. And the example, the one that's on the market now is tirzepatide, which is a dual GIP and GLP-1 agonist. Glucagon, this brings a completely different story here because glucagon receptors are highly expressed in the liver, whereas there are no GLP-1 or GIP receptors on hepatocytes. Not only that, with glucagon agonism, it's thought that there's an increase in energy expenditure. So in a sense, you're working on both sort of sides of the equation for weight reduction. You're decreasing through appetite suppression, decreasing energy intake, and then these drugs are thought to actually enhance energy expenditure. So very good for weight reduction. There is a slight increase in insulin secretion, which is sort of a paracrine effect. At the level of the liver, though, there is increased beta oxidation, a reduction in de novo lipogenesis. From a diabetes perspective, though, there is increased glycogenolysis and gluconeogenesis, so an increase in hepatic glucose output. So probably not drugs necessarily the dual agonists, which are survodutide right now, which is Boehringer Ingelheim's drug, and pemvidutide, and there are others, which is Altimmune. Probably neutral with respect to glucose. You're not going to get a reduction because, you give glucagon as the drug of choice when someone's having hypoglycemia. So agonizing the glucagon receptors, you're going to get increased hepatic glucose output. But very important molecules, I think, for metabolic liver disease. And the big one here is retatrutide, and this is a triagonist of the GIP, the GLP-1, and glucagon receptor. So we'll talk a bit about that. And retatrutide now is in phase 3 of clinical development for type 2 diabetes and for overweight and obesity. And I was just talking to Rohit in the break room. He says there's some work going on in metabolic liver disease. I'm not aware of that personally, but let's start real quick with the selective GLP-1 receptor agonist. Again, the most potent is semaglutide. Here's the structure. The bottom line, it's got a long half-life because it's got this 18-carbon fatty diacid moiety that's attached to it, some substitutions in amino acids, which prevents cleavage and inactivation by DPP4. And this allows it to have or be a once weekly injectable. So again, this is semaglutide is Ozempic for type 2 diabetes, Wegovy for obesity, and this was approved for diabetes in 2017, and then in 2022 for overweight and obesity at higher doses. And there's an oral form as well, which is Rybelsus. And the STEP trials were the phase 3 programs. This was a phase 3 program that led to the approval of semaglutide for weight loss. And you see in these studies in people without diabetes, you're getting an average weight reduction of close to 20%, and the mean's usually the median. So you have about 50% of the patients having greater than 20% weight reduction, clearly better than placebo. And this is as good as it got at this time. In diabetes, about a 10% reduction. In all of these obesity trials across the board, people with diabetes lose less body weight than people without diabetes. And that's important when you look at these metabolic liver disease studies, like the recent articles in the New England Journal for survodutide and tirzepatide. Those studies have, a majority of the patients have type 2 diabetes. So you've got to take that into consideration when you look at the weight reduction in those trials. So this is the phase 2 study in people with biopsy-proven MASH, and these patients had fibrosis, either stage 1, 2, or 3 fibrosis. You can see it was a 72-week paired biopsy study. And at this point, Novo Nordisk was looking at once daily semaglutide. And you see the highest dose here at the top is 0.4 milligrams a day, which is very close to what the dose is being studied now, which is the 2.4 milligrams weekly. So this equates to 2.8 milligrams weekly. You see 3 different doses and the typical primary endpoint. So resolution of steatohepatitis with no worsening of fibrosis, an improvement of fibrosis without worsening of steatohepatitis. And the bottom line, what we're seeing is that there was an improvement in NASH or MASH with no worsening, or resolution, I should say, with no worsening of fibrosis, particularly at the higher dose. But the other endpoint, which was improvement in fibrosis with no worsening of NASH, did not reach statistical significance, but it was marginally better. And this could be due to the amount of time on drug. I think these patients also, they lost about, it was just north of 10% of their body weight. But there could be, there probably is some limit where you can lose all the weight in the world and you're not going to get more fibrosis improvement. There probably is some ceiling. And that's where combination therapy may be important as well. And this is a trial that Rohit described in great detail, the ESSENCE trial. So this is Novo Nordisk phase 3 trial looking at semaglutide, in this case 2.4 milligrams once weekly in people with biopsy-proven MASH, and in this case stage 2 or 3. And as he mentioned, this was really enriched for the stage 3, and I think it was 70% or so of the patients had stage 3. Over half of these patients had type 2 diabetes, and what was reported out was part 1, so the sort of the biopsy histologic portion. Clearly, we'll need to see what happens to long-term outcomes over time, and he showed this as well. So it met both of its endpoints. So this is one of the first times we saw this with survodutide, and certainly a hint of this in phase 2 with tirzepatide, but an improvement not only in the patients with resolution of steatohepatitis without worsening of fibrosis, but also improvement in fibrosis without worsening of MASH as well. I would say placebo does fairly well. That definitely is a statistically significant difference, but there is room for better, and we'll just need to see over time if this improves or not. And these patients had nice weight loss as well. And we certainly know, I'm not sure why I put this slide here, but the weight loss improves many things, including metabolic liver disease. And certainly when you start getting to 10, 15% or greater than 15%, you get improvement in all of these things, including cardiovascular mortality. And with these agents, as you'll see, particularly these dual and triple agonists, we're getting to this degree of weight loss quite frequently. And that's what we see in the clinic as well. And it's got its issues, and I'm going to get into the side effects and some potential issues here. One of the key issues is, and we see this with all of these agents, and this is from step 1. So this was the first of the semaglutide 2.4 milligram obesity trials. And what you see here is that at 68 weeks versus placebo, I mean, great reduction, almost 18% on average. This is in people without diabetes. But then in the extension study, basically semaglutide is stopped, and this is what you get. So these are, in general, I can't speak for every single patient, lifelong therapies, and the patients have to stay on them. Unfortunately, if you look at the literature and look at claims data, and even listening to Novo Nordisk CEO, about 70% of patients who start semaglutide are off of semaglutide by 1 year of treatment. So I do think that metabolic surgery does have a place in patients who cannot stay on these medications, or patients who can't tolerate them or have contraindications. And certainly many patients need metabolic surgery and these agents, and that's been looked at very carefully. Just a couple of other things with respect to selective GLP-1 receptors agonists. Orforglipron is a small molecule GLP-1 receptor agonist that's oral. It's once a day, with or without meals. This is a phase 2 study we published last year in people with diabetes. This is not an obesity trial. The obesity study was published at the same time in the New England Journal. And what we saw is just tremendous improvements in hemoglobin A1C compared to dulaglutide. You could see there, which is Trulicity, at a 1.1% reduction. We saw a 2.1% reduction with this pill. And this is only 26 weeks. If you notice in all of these weight loss studies, even at week 52, you haven't seen a plateau in the weight on average. It usually goes beyond that. But at 26 weeks, we already saw around 10% weight reduction in these patients at the highest dose. So this, I think, in the future could be, very important. We do have peptidic oral GLP-1 receptor agonist, semaglutide. But that's given at very high doses, 14 milligrams once a day. There have been studies at 25 and 50 milligrams once a day. The bioavailability is terrible. If you can imagine 50 milligrams once a day compared to 2.4 milligrams injected once a week. And there's some restrictions as to, when you can eat after taking it, et cetera. I mean, very difficult to get absorption of a peptide. These are non-peptidic. These are small molecules that don't seem to have any off-target effects at this point. And orforglipron now is in phase 3 for type 2 diabetes and for obesity. And I imagine it will be looked at. Certainly there's sub-studies looking at MRI-PDFF, for example. And the only other one I will talk about, because I think this is very important, is a Novo Nordisk compound that's also in phase 3 now for type 2 diabetes and overweight and obesity, which is a combination of semaglutide, the GLP-1 receptor agonist, and cagrilintide, which is a once-weekly amylin analog. So we're back to amylin after 25 years or whatever. Very powerful. This is a study we published last year. It's a type 2 diabetes study, not even an obesity study where you get more of the weight loss because they're seeing dietitians, you give them 500 calorie deficit diets, et cetera, et cetera. But this is a weight reduction at week 32 and certainly no plateau here, 16% with the combination of cagrilintide and semaglutide versus 5% with semaglutide alone. And this is semaglutide at 2.4 milligrams, which is semaglutide at the Wegovy obesity dose. So very powerful combination. And again, in phase 3 for diabetes and for weight management, I am sure this will be looked at in metabolic liver disease as well. So moving on here. Oh goodness, we are tight on time. So tirzepatide is a dual agonist of GIP and GLP-1. We talked about that. This is what we call a unimolecular multi-agonist. So it's a single molecule. It's based on the peptide or the background sequence, I should say, of GIP, and it's been modified to bind to and activate both receptors. Long half-life, similarly to semaglutide. So it's a once weekly injection. This is the only study actually that was a head-to-head at this time for diabetes of tirzepatide versus semaglutide, much, or I should say better with respect to glycemic control, and got 12% weight reduction in a diabetes trial, which is the most that had been seen, compared to 6% with semaglutide at 1 milligram. So the tirzepatide, very potent for glucose and for weight loss. This was a sub-study done in one of the tirzepatide phase 3 trials that looked at MRI PDFF. And in this study, greater than 30% relative reduction in liver fat was seen in about 80% of patients, and about half of the patients had a reduction less than less than 5%. So basically normalized the liver fat. And here's one example that was actually published in this paper in Lancet of a patient who had 27, the liver fat content 27% after 1 year of treatment with 5 milligrams, which is the lowest dose of tirzepatide, down to 2.6%. And this patient had a 20% reduction in body weight, which was likely driving a lot of this. If we look at the SURMOUNT studies, this is the phase 3 program for tirzepatide in overweight and obesity. Now you're getting to mean reductions in body weight of about 25%. With semaglutide, it was somewhere around 18 to 20%. In fact, last week, there was a press release that came out of SURMOUNT 5, which was the first head-to-head study, compared tirzepatide for obesity versus semaglutide 2.4 milligrams, and the weight reduction was significantly greater for tirzepatide, about 20% versus 15% for semaglutide. And I'm sure, there'll be a ton more details when that gets published. I don't think it's been published yet. And as with other trials in type 2 diabetes in the study SURMOUNT 2, less weight loss, but still 15% at the end of that trial. And Rohit actually published this earlier this year, which is a Synergy NASH trial, which is looking at tirzepatide in patients with biopsy-proven MASH with fibrosis, and there was an improvement both in resolution of NASH on the left with no worsening of fibrosis, as well as an improvement in fibrosis stage with no worsening of MASH. So I think this is very encouraging for a phase 2 study. As with semaglutide, what this shows here is if you stop the drug, and these are interesting studies because you start everyone on the drug. So it's open label. They know they're on it. You get to week 32, they've lost over 20% of their body weight, and then they get randomized either to continue the drug or to placebo, and it's double blind. So these poor people that go on placebo, they increase. So again, lifelong therapies. Survodutide and pemvidutide. So this is a combination of GLP-1 with glucagon agonism. So you're really dealing with not only indirect effects on the liver from the GLP-1 receptor agonist, but direct effects from glucagon receptor agonism. Survodutide, this is an obesity study that was published earlier this year, actually. Very nice reductions and certainly no plateau yet at 48 weeks. And this was published this year, which is looking at survodutide in biopsy-proven MASH. And as with the Synergy NASH and with tirzepatide, improvements in both of the endpoints, so some improvement in fibrosis as well. I can tell you that in this trial, and I think the dosing algorithm has been changed, and it's very important to dose these drugs and starting low and going slow. Somewhere around 20% of the patients at the high dose group dropped out due to GI side effects. Most of that was GI, but I think that'll get work done. Certainly when we studied tirzepatide in phase 2, we got got to the 15 milligram dose in 6 weeks, and about 25% of the patients dropped out. When it launched, or for phase 3, we got there in 20 weeks. So we tripled the amount of time it took to get to the 15 milligram dose, and only 4 to 5 patients or % of patients dropped out due to GI side effects. So lastly, and I'm going to take just a couple more minutes, is the triple agonist, also based on the peptide sequence of GIP and now modified to bind to GIP, GLP-1, and glucagon receptors. Once weekly dosing in phase 3 for type 2 diabetes and obesity. And this was the obesity trial that was published last year, looking at people without diabetes, 25% weight loss on average with retatrutide. And look at this, 50% of the patients almost lost greater than 25% of their body weight, and about a quarter lost greater than 30% of their body weight. And this is a really cool analysis from this paper that we published with Arun and Lee Kaplan, which looked at patients in this study, in the phase 2 study that I just showed, or phase 3 study, I'm sorry, I just showed. And it was patients who had MRI-PDFF liver fat content greater than 10%. So you can see their overall baseline was 19%. And over 80% relative mean fat reduction on average, over 80%. At week 24, it was 82. At week 48, 86%. And look at these responders. I mean, Rohit called, greater than 50% the quote unquote super responders. And, super responders, 100%, and over 70% relative reduction in liver fat in 80% of the participants. And then we looked at all kinds of markers of Pro-C3 and, all the ELF and markers of fibrosis, all improve here across the board. And this paper's been published. Side effects real quickly. The most important are GI side effects. Nausea, vomiting, diarrhea, constipation. In practice, they're not, I found, as common as in the trials. Many times in the trials, we are forced to titrate and we're blinded, so we can't de-escalate. When I'm using these in practice, first of all, I rarely get to 15 milligrams of tirzepatide. My patients do great on 5, 7.5, 10 milligrams, and I titrate based on the effect, and I don't want them to lose too much weight, because one of the other big issues is down at the bottom here, which is sarcopenia. And I do not want skinny patients who do not have any lean body mass, because they will go losing some of that. This is a really nice paper actually in postgraduate medicine, which talks about the importance of educating the patient about the potential of these side effects, escalating very slowly, de-escalating if you need to. And oftentimes we do use medications to really take care of the symptoms of these side effects, because they are almost always, I shouldn't say always, but almost always, they're temporary. Sometimes I can switch someone from semaglutide to dulaglutide or to tirzepatide or vice versa, and they will have a side effect to one and not the other. I don't have any idea why. And then make dose adjustments. This speaks to the muscle loss. This looks at step 1 and surmount 1. So semaglutide and tirzepatide, and looks at the annualized loss in lean mass. And what's on your left is what they calculated as sort of age-related. This is what you would expect as someone ages, about a 0.5% reduction in lean mass annually. But look what you see with step 1 and surmount 1. I mean, 10%, 8%. We do not, or we want to minimize this. I mean, the ratio of fat, I mean, they lose much more fat than lean mass. So the ratio ends up good, but we want them maintaining as much lean mass as possible, and really want sort of what I would call quality weight loss, which means maintain muscle mass and lose fat. And that's basically what this is saying here. No need to, and I send the patients to, I certainly don't have the expertise or time to do it, but they should be eating at least 1 gram of protein per kilo. So, I mean, but they go to the dietitian and get all that. And I think the physical activity, particularly the resistance training, is critically important for this. And there have been studies looking at this with liraglutide, and they actually lose much less lean mass. And it's kind of obvious if they have a decent diet and they do some physical activity. And you want to prevent this so-called sarcopenic obesity. I mean, what ends up happening is this, with what's been called weight cycling, they lose a lot of weight and they lose a lot of lean mass. They come off these drugs for whatever reason. And then when they gain all the weight back, all they gain is a bunch of fat. They don't gain lean mass again. So you end up at an even worse ratio. So this could be problematic, particularly in older patients. I'm very careful with my elderly patients with these drugs. I can't tell what's going on with this clock. It's almost winding down and then, but anyway, Paul, just tell me when to shut up. Okay. So in older adults, I think this becomes really important. And in fact, in the SELECT trial, which was a cardiovascular outcomes trial of semaglutide in patients without diabetes, and we showed that in those patients, there was a reduction in cardiovascular risk, but there were more hip fractures, particularly in elderly patients. So hip and pelvic fractures you see there with Wegovy. This made it into the label. Who knows why? I mean, you lose a lot of weight, you lose your cushion if you fall, but also, you lose a lot of muscle. You may have some instability as well and not fall as well. But I would say lots of caution here with respect to that. And what does the future hold? This is a really nice paper actually by Dan Drucker, who's like one of the gods of, incretin-based therapies. And on the left here, you see kind of where we are today, peptide agonists, these multi-peptide agonists, such as, tirzepatide, retatrutide, and many others on the way. Oral peptides in these small molecules, but then, other therapies that are coming, more advanced therapy, cell-based therapy, gene editing. I mean, that's down the line. And I certainly don't know a whole bunch about those, but also on the right, I mean, this whole concept of multi-agonists. So really hitting multiple receptors to get the best effect and get it as safely as possible. And as an example, I mean, Lilly acquired a company that has it's primarily in the muscle, but an activin 2 receptor. It's a blocker, it's an antagonist, and that should either maintain or actually increase muscle mass. So now the companies that are losing all this weight, they're going to add something else, which adds expense. But I think, just proper patient selection, diet, resistance training, and hopefully something will come at some point where patients can lose weight and not lose a lot of muscle mass. So we have all of these disorders, again, at the center of this: insulin resistance, overweight, obesity, clearly important. The GLP-1 receptor agonists, sort of pleiotropic effects that have positive effects on all of these. So we've seen, with respect to the liver, clear improvements in steatosis. I would also add to that in inflammation as well. Starting to see this year in trials some improvement in fibrosis as well. I personally think that over time, with this level of weight reduction, we'll probably see more improvement in fibrosis. So it's been nice to look at that. And I'll end just saying that as we do in diabetes now, I mean, I rarely have a patient that's on less than 2, 3, even 4 medications with complementary mechanisms of actions where we can keep the doses maybe lower, better tolerability. I foresee that, and not just me, any expert who talks about this, foresees that will likely be the case for metabolic liver disease, given the multiple pathophysiologic defects that lead to it. But I think these GLP-1 based therapies, although they have their issues with tolerability, we need to select the right patient, use them appropriately, will probably be the backbone or the background for most therapies for metabolic liver disease. So with that, we'll end and look forward to the Q&A later. Thank you.
Great talk. Thank you, Juan. Okay. We're now going to do updates from AASLD. First on viral hepatitis, I'm going to do that for you, and then we're going to do transplant abstracts are going to be done by Jeff Kahn. So just to remind you, I'm from Scripps. I've been there 39 years. Currently the director of Liver Disease Center there, and I'm also got a faculty position at the Research Institute. These are my disclosures. And I'm going to talk about viral hepatitis in brief, not very much about hep C, no new drugs. I'll talk a little bit about elimination. Most of the talk today will be about new drugs in hep B and delta, two exciting areas where there's a lot going on. So I'm going to start by first giving a little recognition to Dr. Gish, who's been preaching for years that we should be treating everybody with hepatitis B instead of following the guidelines. The current guidelines for AASLD and EASL indicate that we treat patients that have a viral load above 2,000 with an abnormal ALT. So in this study done in China, PAN looked at a large group of patients, 450 patients, and divided them into groups, two groups. One patient population had a low level of viremia and a normal ALT, and the other had an undetectable HBV DNA completely. And then they followed them to determine whether or not they develop one of these complications, either intermediate phase or actually fibrosis or cirrhosis. And what they found was interesting is that the patients that ended up progressing into the indeterminate phase, they called, that's where they could progress to liver disease, actually were the ones that had the low level of viremia, and the patients that were undetectable did not do this. They also found that the undetectable patients were much more likely to lose surface antigen over time. Keep in mind, this is over a long period of time, as opposed to those people with low level viremia. So they concluded that you're better off if you have an undetectable DNA, and that maybe we should be treating all these people with positive hepatitis B surface antigen that have low level viremia, and that would change the guidelines significantly if that was done. So we're not doing that yet. So just to remind you, this is old data based on the old hepatitis B guidelines. We don't do a very good job of losing surface antigen with our current nucleoside or nucleotide analogs. So if you look in Entecavir, tenofovir, TAF, basically nobody loses surface antigen on these drugs. If you take PEG interferon, you're more likely to lose surface antigen, but most of our patients are e antigen negative, about 90% are e antigen negative, so it doesn't happen that often, and you have to take interferon for at least 24 weeks in combination with a nuke, and we have a hard time convincing patients in the United States to do that. So by and large, we're stuck with these nukes that patients are on for life, and the number of patients that actually lose surface antigen is small, 1% a year or less. And this has been an impetus for new drug development. So does it do any good to lose hepatitis B surface antigen? I think we have a good answer to that question. This is a study done in Hong Kong in over 20,000 patients, and they looked at patients that were had no suppression of their viral load or inadequate suppression versus those that were suppressed to an undetectable level, and they found it dropped the rate of liver cancer over an 8-year period by about 1%. So that was good news. But if they lost surface antigen, that risk of HCC dropped below 0.5%. So that's an important number because that's below the level of cost effectiveness for screening. So theoretically, they would no longer be patients in a cohort that requires HCC screening. So it certainly does help if you're able to lose surface antigen, even though we're not able to do that very often. So because of this, there's a ballooning development of new drugs for hepatitis B. This was from a review article in New England Journal of Medicine last year, and it showed there are a number of approaches you can use by blocking the viral replication phase, starting with entry and then replication in the nucleus, and then RNA interference inhibitors of hepatitis B surface antigen release, polymerase inhibitors, which are, of course, the drugs we currently have approved, and CAMs, which are in development. And besides this, you can also work on the immune side of the response using using basically drugs that are PD-1 monoclonal antibodies. So these drugs are used for cancers, of course, but they also disinhibit the immune system and allow you to clear virus in some patients with hepatitis B. So you have to use it in an attenuated form and be careful with it. There are also TLR receptors that do the same thing. And besides this, you can actually have direct sterilization approaches where you block the cccDNA in the hepatocyte. So far, we have a number of drugs in development. This was in the same article in New England Journal of Medicine, and it showed you how many drugs were in development at that time. And the one that's farthest along really is a drug that is an siRNA or an antisense oligonucleotide. This is being developed by GSK, and this drug works by blocking it creates RNA interference with the cccDNA that's released and from the nucleus. And keep in mind, there's also virus in the integrated genome, so it blocks both of these. It blocks the step where there's an intermediate RNA that's then released into the cytoplasm. Unfortunately, it's an injection, and you have to take the injection every day. So this drug is called BEPO for short, and it's in phase 3 development right now with or without PEG interferon, and we'll see where it goes, but the early data published in New England Journal of Medicine looks promising. So at this year's AASLD meeting, we saw this list, and this should remind you of where we were with hepatitis C about 5 to 10 years before we had our first approved drugs that were direct-acting antivirals for hepatitis C. So there's a whole lot of drugs in early phase 1 or phase 2, and there are 2 drugs in phase 3, BEPO, the one I just talked about, the antisense oligonucleotide, and bulevirtide, which is an entry inhibitor that's used primarily for Delta, although it blocks the same entry for hepatitis B. But there's a huge pipeline of drugs in development. So I'm going to talk about 3 of these that were presented at the meeting, although there were many presented. So I just picked out 3, and Tatiana Kushner lent me some of these slides. This was presented by Ed Gain, and it's an end of treatment study of 2 drugs made by Vir. One drug, tobevart, is a monoclonal antibody, and the other one, elebsiran, is an siRNA. So using both together, and they did this with or without, with PEG interferon or without PEG interferon, and this is the analysis right here at the end of therapy. That's important because it turns out with hepatitis B, you lose effectiveness over time when you monitor patients. So at 24 weeks off of all therapy and off of nukes, that's where you assess a patient for a cure or sustained virologic response. And that will be the telling data. Now, we don't have that yet, but at the end of treatment, they did achieve 22% surface antigen loss, not bad, with PEG interferon, 16% without. And you were much more likely to lose surface antigen if you start off with a low surface antigen titer. So we check hepatitis B surface antigen titers in every patient that we follow on a nuke that is E antigen negative, that does not have cirrhosis, that has a normal ALT and has cleared virus. In other words, they've got an undetectable HCV RNA for 24 months. And I can tell you less than half of them have a viral surface antigen titer below 1,000. So it's a problem. You have to select these patients. They're much more likely to have a functional cure. But at any rate, this combination looks like it may be effective. There's a second study. It's a hard slide to read, but this is from Arbutus, and this is a Canadian company, and they have a drug that they call imdusiran, and this is a single agent they used in combination with PEG interferon. And the bottom line is they were able to achieve surface antigen loss in 50% of patients with the development of surface antibodies. So this is surface antibody in many of these patients. And this was when they used it in combination with 24 weeks of PEG interferon, and was seemed to be well tolerated. But the problem was the patients that tended to have the cure were the ones that started with the lowest surface antigen titer. So again, that seems to be the issue. You have to start off with somebody that's more likely to lose surface antigen. And there was a third study. This is from a company that's called Blue Jay in the United States. And this is using an immune stimulator alone in place of pegylated interferon. And they were able to show the same loss of surface antigen, but again, they had the best response in people with started off with a low surface antigen titer. So that there were a number of other drugs. If you're interested, these are the abstract numbers. Most of these were presented as late breakers, but they all were similar, and the similar theme in all of these are that you're required to take a nuke at the same time. You had to be nuke suppressed to begin with, and you may have to take the nuke afterwards for some period of time. Number two, you're dependent on a low viral load or surface antigen load, excuse me. So you're selecting people with a low hepatitis B surface antigen titer for a cure, and you have to use interferon for many of these regimens to get an effective response. The other thing is the end of treatment response and SVR are not the same thing. So we have a ways to go. This is similar to, if you remember, 10 years before we had our first DAAs for Hep C, we were arguing about genotype 1A versus genotype 1B and whether you had to use PEG interferon or not and how long you had to treat the patients. So a lot of the same issues have come up with hepatitis B, and it's going to take a while, but I think it will happen eventually. I think we will have drugs that are able to do this. Now, let's talk about delta hepatitis. So in June, there were 3 papers published in the New England Journal of Medicine simultaneously with their presentation at the EASL meeting in Europe. So anytime that happens, that should signal to you there's going to be a change in the standard care. So 2 of these were on NASH, and you've heard about those this morning, and about the drugs. Juan Pablo just told you about the drugs, but one of them was on delta hepatitis. So this tells you that there's going to be a change in the standard of care for delta. So to remind you, those of you who were not around in 1977, I was a medical student in 77 when Mario Rossetto discovered this, delta hepatitis. It's a satellite virus. You can only be infected with it if you already have hepatitis B or you get infected with hepatitis B at the same time. Affects 10 to 20 million people in the world. Why do we care? Well, because it's the most severe form of chronic viral hepatitis there is. So that's why we care, because it can create a lot of problems. So in the United States, the prevalence of delta is not that high. You can see the parts of the world where it's most prevalent are Africa, the Middle East, some parts of Asia, Central Europe, and some parts of Brazil. The risk transmission for delta is like hepatitis B, sexual transmission, injection drug use, mother to child, etc. So, but why we really care is that if you're infected with delta, as opposed to just Hep B, your risk of a liver-related event or liver death or liver transplant is twice that of just Hep B alone. So if you look at patients that have delta, their overall risk for liver cancer is 2 to 6 times as high as that of just hepatitis B patients, and their risk of developing decompensation and death is 2 to 3 times as high. So I haven't seen a lot of delta patients in my practice, but of the ones I've seen, most have cirrhosis, and that's not unusual to diagnose them at that point. So that's why it matters. Now, have we had anything to treat these patients with? Yes, just PEG interferon for the last 20 years, but problem is about 2/3 of patients are eligible, but of those, only 26% get a response, and only 18% of those get a sustained response. So it's not a very good clearance of the virus. It's the best we can do, though, and you're asking patients to take a very difficult therapy. Now, it does change survival. If you're taking a high dose of PEG interferon, you're much more likely to survive than if you're a control or taking a low dose. So this was data presented by Patricia Farzi 20 years ago, and I still send patients to Patricia in Italy to deal with this, because it's such a hard thing to ask patients to do, is to take PEG interferon for that period of time. But because of that, there's been drug development in Delta, and it so far is targeted the sodium taurocholate transporter receptor on the hepatocyte. This is a receptor that Delta uses to get inside the hepatocyte. It's also the receptor that hepatitis B uses to get inside the hepatocyte, so you can block that receptor and get a double bang, money for your bang there. You can get both viruses blocked. And then once you block the receptor, it can't do the next steps required in replicating inside the nucleus and being released. The drug that's farthest along is bulevirtide. And this paper was published by Heiner Weidemeyer 2 years ago, showing that if you give bulevirtide by itself, you get a viral load reduction of 2 logs, that's considered a response, in about half the patients. And you get normalization of liver enzymes in about half the patients. So that was enough to make it into the New England Journal of Medicine a couple of years ago. Notice they studied it at 2 doses, and the drug was approved in Europe at the 2 milligram dose and is being used there regularly. So we also have data now showing that you can give the drug to people with more advanced liver disease. These are patients with cirrhosis with portal hypertension, but it's also been given to patients with decompensated cirrhosis, and they also drop their viral loads and their ALTs. And I've talked to a number of physicians who have used the drug in patients with portal hypertension and cirrhosis or decompensated cirrhosis, and it appears to be safe as a monotherapy, and it's getting people off the transplant list. So it's doing what the first drugs did for us in hepatitis B, is switching a patient from being decompensated to compensated. As long as you leave them on the drug, they have to stay on it. So that led us up to this paper that was published this year by Tarek Aslan from France, using combination of bulevirtide and PEG interferon. And what they showed was at the highest dose, the 10 milligram dose, combined with PEG interferon, they had SVR rates, sustained virologic response rates of almost 50%. And a combined SVR and normalization of ALT of 40%. So that's the best response we've seen yet. And I think that will lead to approval of this drug with PEG interferon in people that can tolerate it in the United States. The side effects in the trial were pretty well manageable, but the problem is you're on 2 injectable therapies for 48 weeks. So that makes this a real challenge. And most people did not stop the drug, but I think it's likely to get approved this year. Now, because that was relevant, at this year's meeting, there were a number of abstracts on the prevalence of Delta, since we're going to have therapy for Delta. How prevalent is it in the world, and how prevalent it is in the United States? This abstract was from Georgia and showed the overall prevalence in the Hep B population was 3.7%. So not huge, but they had a large number of patients. In this study from Canada, they had 2 different populations. One were referred And that was 4.2%. So the doctors suspected their patient might have Delta infection. The other was just chronic infection. That was 1.1%. In the United States, we have a large VA trial showing that overall prevalence was 3.1%. Most of these were substance abuse users, IV drug users, and they also had outcome data on this population showing they were much more likely to get liver cancer or decompensate. And we looked at our population in Scripps. This was done by Karen Musa, one of our residents, but we tested 593 out of our 2,400 patients with Hep B. We tested the ones using AASLD guidelines that, might have a risk. And we compared that to Bob Gish's population at La Maestra in downtown San Diego, where they had a much higher prevalence of IV drug use and MSMs, et cetera. They had 118 patients that were tested. In both populations, the prevalence was only 2.5%. So not very high, and there did not appear to be a difference in the demographics between those populations, but this is a small study, so we'll see. So anyway, at the meeting, there's a long-term follow-up from Europe in a real-world trial. Because the drug's been approved in Europe since 2020, they've been collecting data. This is called the SAVE-D trial, where they've got people on bulevirtide for a long period of time. And the good news is that after 120 weeks, so this is 2 years, the effectiveness, 75% achieved viral loss, over 50% achieved normalization of ALT, and about half the patients had a combination response. So that's quite good. And that's on monotherapy. So if you take patients with Delta hepatitis that have more advanced disease, they're likely to lose virus and normalize their liver test and remain alive and compensated on this drug. How long do you have to use it? We don't know yet. Not clear. So my guess is where we're going to see this drug used in the United States, I think it'll be approved. If you do not have a contraindication interferon, I think you're going to give it with interferon. I'm not sure about the 2 milligram dose. It could be 2 milligrams in Europe, might be 10 milligrams in the United States, probably for 48 weeks. If you have a contraindication to PEG interferon, you'll just get the drug. And I'm not sure about the dose. It could be 10 milligrams. If you've got compensated cirrhosis with varices, you can take it. And if you got decompensated cirrhosis, you may be able to take it. So I think this will be a useful drug for Delta. How much Delta we really have in this country, it does not appear to be a lot, at least not in our population. Now, that's not the only way you can get rid of Delta. That's an entry inhibitor. There's also immune modulators, prenylation inhibitors, secretion inhibitors. There's all kinds of other ways to get rid of the virus. This is an example of, this is again, the same regimen I showed you before for Hep B from Vir using an immune modulator and siRNA, and that works for Delta as well. So they're going to study this in a phase 3 trial for Delta hepatitis. There's also a drug from Blue Jay Therapeutics that is an immune modulator, and that's a monoclonal antibody, and it gets rid of the virus in everybody. So the advantage of a monoclonal antibody is it binds up the virus and it will make you aviremic, but it only works as long as you're taking it. So you don't have to take PEG interferon with this drug, but it's not clear if you're going to achieve a sustained virologic response, but just shows you there are drugs in development. So I'm going to take the last 15 seconds and talk about hepatitis C elimination. This is where we are in the United States. This is data from the CDC, and it shows you the use of direct-acting antivirals. So the year we treated the most patients at our center was 2015. That was true in the rest of the world or the rest of the country. And now they're treating about 80,000 patients a year. And the payer type has changed. So these are insured patients or Medicare patients. That's less and less, and this is Medicaid patients, so that's more and more. And the same with the age of the population. Most of the patients are over 60, so they were in the baby boom population, but we've treated most of them. So we have a couple patients a month we treat now with DAAs, or maybe one patient a month, whereas we used to have 20 or 30. And most of the patients being treated are young patients. So how do you do this? This was a study suggesting a rapid HCV testing is an optimal way to treat people in opioid treatment programs. So if you show up and you can actually do a rapid test at the time the patient's there to pick up their methadone, you can diagnose their hep C, start them on therapy at the same time you give them their methadone, and you're likely to capture the patients and end up with much higher SVR rates, as opposed to the standard of care, which is where you tell the patient, hey, you got hep C, you got to go see a hepatologist. And then it takes 10 years to get an appointment with a hepatologist. And so that doesn't work very well. And the SVR rates really are not very good. So we do have Tony Martinez in Buffalo, New York, who's doing this. He does same-day rapid testing and starts people on therapy, and he's been very successful. So it works. And lastly, there's a study going on using Epclusa in pregnant patients, just so you know this. Right now, it says don't use these drugs in pregnant patients. So this is done in a clinical trial. They've only treated 35 patients, but all 35 of them achieved an SVR. So it is possible to treat somebody in pregnancy. Why would you do that? You want to prevent perinatal transmission. And that's ultimately why you want to do it. So, but this is still not ready for prime time. So in summary, a large number of treatments achieving a functional cure for Hep B in development. 2 of those are in phase 3, so stay tuned. Bulevirtide, with or without interferon, I think is effective for Delta, and we'll likely see it approved in the United States next year. And lastly, rapid on-site testing for Hep C is useful for opioid treatment programs, and treatment of pregnant patients is possible. Thank you very much. Hey, Jeff Kahn's going to do transplant abstracts, and then we'll wrap up.
I think in the interest of everybody's stomachs, I'll make this a little bit quick. So this is a slide that probably people would consider blasphemy in the transplant world, and that is that, first, maybe a show of hands. Who in the room knows that colorectal metastatic disease to the liver is actually an indication now for liver transplantation? So most don't know that, so that's good. So I remember going to an EASL meeting about maybe 7-8 years ago, and there was a discussion about this by a group in Norway. And since that time, it's become fairly accepted by a lot of transplant programs that this is something we should consider because of improved outcomes for patients who actually have metastatic disease to the liver from colorectal mets, but very, very selected patients. And you can actually apply for a MELD exception if you don't have a living donor. And so it's something that we're doing, other centers are doing as well now. So this is an abstract that was just looking at progression-free survival benefit in real-world evaluation of patients referred for unresectable colorectal liver mets. This was not a study that was shown at this liver meeting. This is the ATC, which is transplant liver meeting. And I'm just going to kind of go to the last slide here. Whoops. Okay. So as you can see on the left-hand side, you could actually see that there's an improved rate of progression, progression-free survival and rate of progression in patients who actually had colorectal metastatic disease liver transplant in the selected patients versus patients who actually got standard of care chemotherapy. And to be clear, the patients who actually had transplants were not treated with any kind of chemotherapy unless they showed evidence for recurrence. The current state of liver transplantation for colorectal liver metastases in the United States, a call for standardized reporting. This is really important. This is actually, again, looking at, how do centers report this kind of stuff, because we have to have some sort of standardized mechanism. Otherwise, we're not going to get enough data. This is like really back in the probably 70s and 80s for liver transplantation, and maybe the 1990s for liver transplantation for HCC, where centers were doing, having different kinds of protocols, and we sort of had to combine data from different centers to get more information. So during the study period, they had 64 patients who were listed for transplants, of which 46 received transplants in 15 centers. And they actually showed that the overall survival rates were actually very respectable in terms of overall outcomes for patients who had standard of care treatment for metastatic colorectal mets, in terms of they actually did better than historical controls did. So I just want to show you our protocol at USC for colorectal mets, and I'm not going to go over the details here, but just keep in mind that the patients have to have stable liver disease. They have to have stable CEA. They have to have biopsy-proven colorectal mets to the liver. No history of any other metastatic disease outside of the liver, and they cannot have recurrence in the colon. And they have to get a certain amount of chemotherapy and be followed for a certain amount of time. And they have to have a very good functional status as well. And again, PET scans and other kinds of imaging to confirm that the disease is confined to the liver. I will say we did our first living donor liver transplant, I think last week or the week before, for a patient who had colorectal cancer mets. And the data is looking quite strong throughout the country for this. So what I learned over the years of sort of being interested in this is it's not a salvage procedure. It has to be somebody with very stable disease in the liver who we think would be most likely benefit from being transplanted as opposed to continuing standard of care chemotherapy. And it's not a salvage procedure. And when this was done very early on, it was a salvage procedure and the outcomes were terrible. So this actually was, impact of pre-transplant immune checkpoint inhibitors. This was actually presented earlier by Jen, so I'm not going to go over this, but I'm just going to go over a couple of things that are important. That is, there are many reasons that we might want to use an immune checkpoint inhibitor for a patient, and I'll show you probably on the next slide what those reasons might be. But number one, we want to maintain patients within Milan criteria, which basically up to 3 lesions, none of which is over 3 centimeters, and up to, or 1 lesion, none of which can't be over 5 centimeters. And AFP has to be less than 500, then they're eligible for a MELD exception. There are also the UNOS downstaging criteria, which used to be called UCSF downstaging criteria, where you can have more lesions. And everybody, always talks about that the UCSF or downstaging criteria are actually more liberal than the Milan criteria, but actually the total amount of tumor can't be more than 9 centimeters in Milan, but they can't be over 8 centimeters with the UNOS downstaging criteria. And the idea is if you can treat somebody to within Milan criteria and also have an AFP less than 500, you can get a MELD exception. So the reasons to treat pre-transplant would be to downstage for a MELD exception, because perhaps there's too much tumor where you just can't do any kind of local regional therapy because it's too extensive, or maybe patients aren't tolerating it. Maybe the hepatic artery, or you want to go through the hepatic artery for localized treatment, and maybe the hepatic artery has been kind of destroyed by prior treatments. Or you want to maintain somebody within Milan criteria. And I think the beauty of immune therapy is that for most patients, it's really well tolerated. And you could take patients who are decompensated with a liver lesion of, say, 4.8 centimeters and hopefully prevent it from growing or shrink it. So that way there's time for them to be transplanted. And these are the various modalities that we would tend to use. But again, I think the ICIs can be very, very helpful. So this was already shown, but I think the bottom line is we were always sort of had the thought, although Brian Lee, who I don't know if he's still here, but he had looked at some data at Mount Sinai when he was a fellow there, showing that you probably don't necessarily need to wait 3 months for washout period after using the ICIs. But that's what most programs have been doing because of the thought that there's a great risk of rejection that could be fatal. And this study actually showed that that only 3 of their patients actually had rejection, none of which was severe enough to cause any long-term effects. And their patients were transplanted. One of them was less than a month, and the other 2 were about 2 months. So, so their outcomes were really, really good. So I think this is really important because it gives us another modality to use. Another big problem is that patients who are post-liver transplantation with recurrent HCC or other kinds of cancers, we traditionally have not used ICIs, but I think we're learning that that if the patients are pretty far out from their transplant, didn't have significant rejection in the last several years since before considering treatment, that we actually could consider treatment because we really haven't had very good therapies, if any, except for surgical for recurrent HCC after liver transplantation. So really my major take is a 3-month washout period maybe is overly conservative. This is interesting. So impact of weekend admissions on liver transplant outcomes in acute liver failure in the United States. All of us who work at transplant centers know that on the weekend, basically the place is closed. So if a patient comes in on a Friday night or Saturday, a holiday weekend, patients just oftentimes can sit there. But with acute liver failure, you don't have time to wait. And the longer you wait to list somebody, the longer, the worse their outcomes are from transplant, and we know that. So really, they just did a retrospective cohort. My biggest question about this is how a UNOS database could actually give you the date that the patient was admitted, but somehow this data seemed to be obtained by this group. And I'll just show you the sort of conclusion. So waitlisting after a weekend or a long weekend is associated with a higher 1-year mortality. And again, it's thought to be due to delays in liver transplantation because of waiting to get them on the list because the testing hasn't been done yet. So I think if we could be more 24/7 transplant program on the weekends, I think we could probably serve our patients better. This is a study, variable treatment and access to liver transplant for alcohol-associated liver disease, California Liver Network, and I'll just go again to the sort of the conclusion here. Oops, let me go back. Yeah, so we basically in California, there was a time when the entire region, actually the entire region 5, which is the region that includes several states, including California, we were looking to sort of standardize practices for listing for liver transplant for alcohol-associated liver disease, especially ALCAP, because otherwise we were finding, and my colleagues in other centers would know, we're calling, patients are going from one center to the other, trying to find a center that would consider transplanting them. And the idea is that if we could actually standardize the practices between programs, we could actually, number one, avoid the cost of patients going around to different centers, decrease the amount of manpower that it takes to sort of, work with these patients. And also it just decrease the time from decision to decrease the time between when you see the patient making a decision to transplant them and actually doing it. And so this study really just showed that referral and selection practices are really suboptimally characterized. We need to standardize the practice. And really the major problem is the psychosocial criteria. So one program, might require a certain number of months of sobriety. One program might require a certain number of caregivers, or one program might say that patients who failed rehab this many times is not a candidate versus another center. And we can really improve quality and probably also improve data collection so we can learn more from the patients. So some of my colleagues at USC actually put together a project to try to figure out which patients might be candidates that we should bring over versus not bring over, because we have a hospital where our transplants are done that's actually, we don't actually have an ER. So all of our patients are transferred in. So the idea is if we could figure out whether patients might be candidates or might not be candidates before coming, that actually we can save time. So on top, these are the questions. So we actually have a social worker who actually calls, talks to the patient and or their caregivers, family members or whomever at the hospital that they're at, and they ask these questions. So when was their first decompensation? Are they encephalopathic? Do they have insight into their liver disease? Will they agree to abstaining from alcohol? Do they have stable housing? Do they have a caregiver or caregivers? Are they using other substances? Any active psychiatric disease? When was their last alcohol use? Number of rehab attempts, past alcohol-related legal issues, either violent or DUIs, number of drinks per day at peak, and then SALT score, which is a scoring system for risk of alcohol relapse. And the major benefit of this is that programs traditionally would maybe call and ask questions from the SIPAT, which is the Standard Integrated Psychosocial Assessment for Transplant assessment that was done at Stanford. And the questions that we ask when we call really just takes a few minutes. This is actually page 8 of 11 of the SIPAT score, so it's very time consuming. So if we just call and ask these questions, perhaps we thought we might be able to determine whether patients should or shouldn't potentially come to our center. So basically what we found is that using so we just divided eras. So either no screening, screening with SIPAT, or screening with this new screening tool that we use. And we found that the SIPAT and this tool are equal in terms of making decisions about bringing patients for evaluation. But it took a lot less time for patients or for our social workers to actually do the evaluation when they just ask very focused questions. And I'm not going to go through this, but we have a sort of system set up with transplant navigators that are 24/7 on call. They work with the hepatologist, social worker, and then once we gather all the data, and the data isn't meant to be a hard yes or a hard no, but it helps guide the hepatologist and the team on who should come over. And as many of you know, it seems like about half of our referrals now are for patients with ALCAP or seriously shortened sobriety from alcohol. There's another study actually by one of my colleagues at USC, which I think it's sort of intuitive, but it's kind of nice. It's the TAP-LT study. So really what they did was they actually provided patients under evaluation for transplant with free Lyft rides to any kind of appointments that they needed to go to. And I'll just share the conclusion. It's feasible, it works. And what we know is, at least from this very small study, and this was an oral presentation at ASLD at the liver meeting, there was actually a mortality difference in patients who actually went through the this Lyft protocol and actually had the rides versus patients who didn't, and that was after transplant. And even though it didn't increase the risk, the rate of being transplanted, the outcomes were better, and the thought is perhaps these patients were actually in better shape when they got transplanted because they kept their appointments. A lot of our patients that get transplanted come in with MEL scores of 40. They're really sick. They're sitting at home. And these are patients that perhaps were seen more frequently and actually came to clinic appointments and also had rides, for instance, even to ERs and things when they needed them. I'm not going to go through this one. Not going to go through that one. So pregnancy outcomes has always been very interesting to me in terms of liver transplantation. And, you know, we've had a lot of patients over the years who have actually delivered. I have probably 10 or so patients who have had multiple pregnancies after liver transplantation. And this is a registry from the UK, and I'm just going to go to sort of the conclusion here. And that is that liver transplant has very favorable outcomes. There seems to be an increased risk of preeclampsia in these patients. And there was another study that showed if patients were transplanted before the age of 10, they had a decreased risk of preeclampsia. And that perhaps in patients that are higher risk, they should be pre-treated with aspirin to maybe help prevent some of the complications of preeclampsia. Another thing that's really important is optimizing immunosuppression. We know that mycophenolate is actually contraindicated in pregnancy. And so if a patient is on mycophenolate, you need to actually counsel the patients if they're pregnant about whether to continue the pregnancy, because there's a very significant risk of very serious teratogenic effects. And so I just wanted to show this slide. So there's something called the REMS. I don't know if anybody's familiar with REMS, but if patients are on not only MMF, but other medications that are highly teratogenic, we're supposed to counsel the patients about that risk and have them sign. It's not a consent to take the drug, but it's a sort of understanding that they understand the risk. You know, we all love for our patients to be compliant. The one time I was really happy when my patient was non-compliant was when she called me and told me she was pregnant and she was on MMF or Cellcept or MMF. And then she actually admitted she hadn't taken it in 6 months. And I was very, very happy. The other thing that we see in the pregnant post-transplant patient seems to be a high risk of actually having cholestasis of pregnancy, and that could be pretty serious. And so I think that, and I don't have a slide on this, but I think in pregnant patients post-liver transplantation, perhaps following fasting bile acids might not be a bad idea, because that can be an early indication of developing cholestasis of pregnancy. And cholestasis of pregnancy does have an increased risk of fetal asphyxia shortly before the time that one would deliver. And so we tend to induce them earlier and perhaps use ursodeoxycholic acid, which may help with some of the risk as well. So this is just my last little section, maximizing the liver donor pool. I'm just going to mention this quickly because you might not have heard about this before. But so DCD, which is donation after circulatory death, is when basically somebody is not declared brain dead. So you have to actually take somebody who we know is not going to survive off of a ventilator, who you actually take off a ventilator, and then if the heart stops beating within a short amount of time, you could actually use that liver and other organs and transplant them. But the problem is, in the liver, these livers end up with what we call ischemic cholangiopathy, which is really bad liver strictures in the bile ducts, and the livers often don't do well. So, and this just shows the number of donation after brain death, which is the blue, versus the top one is the donation after circulatory death. And it just shows you the percentages of livers that actually weren't used because they weren't usable. So the idea is maybe you could do something to make these livers usable. So there are two major kind of things that we use. One is called NMP, which is normothermic machine perfusion. And I'll show you that here. So that's on the right-hand side. So basically you take the liver out and you put it on a machine, hence the name. And then the other one is called NRP, or normothermic regional perfusion, where you actually connect the donor to basically an ECMO apparatus. And basically the idea is you can keep blood flowing through the liver while you're kind of waiting to do something with that liver. And it's been shown that the outcomes are much better for these DCD, and probably for almost any other kind of marginal liver than they otherwise would be. The problem is that for NMP, this adds about $80,000 to $100,000 to the acquisition cost for the liver, which means that if insurance isn't covering it, which most won't, then you're going to be in a deficit for basically almost every liver you do, and then the transplant administration is going to come after you and say you can't use these machines anymore. The NRP, which is the one that's on the left-hand side or the right-hand side, is much less expensive. So this is an abstract that's also from ATC from this year. Nationwide use of machine perfusion demonstrates increased organ utilization and improved DCD graft survival in liver transplantation. And what they did was they just looked at OPTN, which is just a database looking at the number of these livers that were used and sort of outcomes. And I'll just show you here. So just in terms of these are the DCDs on machine perfusion, and this is the survival. And this is without machine perfusion. So you can see going out several years, the outcomes of these livers is much, much better. And also we see that most of the livers that are being put on these machines were actually DCD livers. So eventually we might be using even more of these machines. The other reason that it's very attractive to use a machine is because if you can keep the liver sort of going and healthy, you could sort of eliminate nighttime transplants, actually decrease cost of, hospital costs for OR staff overtime, and also physician fatigue, and perhaps even outcomes based on that. So I'm going to leave it at that. I know I left off some of them, but.
We turn the lights up in the room, please. And we're going to have a panel discussion and then a Lifetime Achievement Award. And then we're going to break for lunch. So we'll start with the panel discussion. If the panelists would mind. We've got some other panelists, Brian, Ray, Arpan, and Jan. Good, thank you. Come on up, and lights on. Thank you. So first question for Juan Pablo, is CMS going to approve these drugs for Medicare and Medicaid, like like President Biden would like? You got to push the button.
There we go.
Yeah.
Unfortunately, do not have an answer to that question.
Okay.
I certainly hope so,
Yeah.
but we should see if they actually work and pull people off if they don't.
Well, might be cost effective eventually. So questions?
Can I ask a question for Dr. Frias? We're seeing this boom of incretin-based therapies these days, and kind of reminds me for us, 10 years ago, I used to present to Jeff about, this patient's on Vicura Pack, this patient's for hepatitis C, this patient's on Epclusa. Do you find that in the future there will be, and we used to do that based off genotypes, in the future, perhaps certain incretins based therapies will be better for certain phenotypes of metabolic disease?
Yeah, no, I think definitely. And I would say, for example, for metabolic liver disease, I think a multi-agonist that includes a glucagon receptor agonist would be critical, and probably triple agonists for weight management. I mean, they tend to have, or not even incretin based necessarily, but combinations with GLP-1, GIP, and some other, maybe amylin or PYY. So yeah, I definitely think so.
Yeah, I think that'll be particularly helpful. I mean, there's one cohort that I find will have a lot of trouble getting some of these medicines without a liver-focused reason, which is the lean fatty liver patient, or lean MASH, I'm sorry. And most of the time they won't hit the BMI, need for the insurance authorization. So I'm pretty hopeful that maybe the glucagon-based incretin treatments will be very helpful for them.
Yeah, although you get a lot of weight loss with those, but I do think the importance of having multiple doses where you can use lower doses in patients who may not need the weight loss. And also, if you look at the studies, I mean, those with the greatest body weight at baseline lose the most weight. Those that tend to not be that, maybe overweight will lose less, which is good too.
Question.
Hi, Jasleen Singh from UCLA. I have a two-part question about transplant oncology for any of the panelists up there. But the first part of the question is for transplant oncology, for colorectal, liver mets, or neuroendocrine tumors, cholangiocarcinoma, really pushing the envelope. What do you think is the hepatologist's role in evaluating these patients? And then my second part of the question is, are you changing immunosuppression after transplant? Are you trying to put these patients on mTOR inhibitors afterwards?
Jeff, you want to take that first?
I think the hepatologist role is really important, because when you sit in tumor boards, oncologists are very important, surgeons. But number one, especially HCC and maybe the less controversial ones, is transplant the best option for them? Are they really surgical, resection candidates and all that? The other part of it, I think, is perhaps, what can we do to keep the patient as healthy as possible to try to treat their cancer, say, if they're maybe going to be a transplant candidate. Because if somebody just ends up, either decompensating and dying, or because they didn't get the right therapy, or maybe the oncologist thinks, we can't treat the patient with like TACE or something because they're going to decompensate, and they're already kind of decompensated, but if we don't treat them with anything, they're not going to get transplanted and they're going to die, and kind of looking at sort of what's the likelihood of being alive in 5 years versus what's going to happen in the next week or so. So I think we're really important. And I think for cholangio and the colorectal mets, it's kind of a new frontier, especially for intrahepatic cholangios. And then, yes, mTORs are in our protocol, and I think most other protocols as well. Again, for those who aren't that familiar, the mTORs are one of the classes of immunosuppression that seems to be involved with pathways or inhibit pathways of carcinogenesis for all sorts of cancers. So it is in the protocol.
The other thing I'll add is that I've just noticed when having multidisciplinary discussions that fields that are outside of hepatology are really scared of their treatments affecting liver function. So, if someone has any sort of fatty liver disease or any abnormal liver enzymes, and then they're offering chemo, there's obviously the hepatologist that will have to advocate for the fact that we have to follow treatments and follow their liver function and not just be like, okay, it's an X because they have elevated liver enzymes. So I think it's just also some co-education we could do to our colleagues about, it's okay to push the envelope with some of the treatments.
Dr. Lee.
I do agree as well. I do think that there's a huge role for hepatologists when we're managing these patients. I mean, for instance, cholangiocarcinoma, and next year there will be a MELD exception for intrahepatic cholangiocarcinoma. And the survival is great when you're thinking of the oncologic outcomes. 3 or 5 year survivals are around 70, 60%, transplanting those highly selected in cases of intrahepatic cholangio. But I think those patients still need to be reviewed by a selection committee, because oncology cancer does not exist in a silo, and these patients definitely can have coexisting other medical comorbidities as well. And we know just from the just your typical transplant patient that their outcomes are highly impacted by other comorbidities. So I still think there is a very large role for a hepatology and just a committee in general for selecting these patients, and not even just cholangio. Not every intrahepatic cholangio case, even if it meets criteria, should proceed with transplant.
Dr. Wang.
Yeah, I agree that it's really a multidisciplinary approach. I think the role of a hepatologist is also, I think sometimes our goals are a little bit different from the other specialties. So we also have a role in kind of looking at the risk benefit and the quality of life that transplant may or may not afford them. That's really important, and really looking at them at patients as a whole being, and not just are they a transplant candidate or not. I agree in terms of immunosuppression after transplant, mTOR would be in our protocol as well.
Brian Lee, you guys gonna be doing liver transplants at Hoag? In Newport Beach, you're gonna have to drive up in a gold Rolls Royce to get a liver transplant in Newport Beach?
I know, right?
Yeah.
You get a nice view of the ocean now.
Yeah, okay.
Probably not anytime soon.
So should we be transplanting colorectal cancer?
I think so. I mean, to me, when I see I'm not an oncologist, but it seems like colon cancer, as long as the sort of initial site has been treated with surgical resection and say they develop a metastatic lesion in the colon, they actually have pretty good outcomes with some sort of directed treatment towards that metastatic lesion. And like Jeff mentioned, as long as it's a select group of patients who have well-controlled disease, I think it's a great option.
I think the reaction we get when like opening up the doors to other diseases is that it's like a zero-sum game, and now we're sharing the pool with other conditions. I think that's like the reaction I initially have, but these are also very well-selected patients with stable disease and probably make up a very small number of individuals, and they're looking for alternative treatment options. So I don't think we're opening the door to like a significantly high amount. We're just expanding the pool just a little bit.
So I noticed out of the like 400 or 500 patients referred, they only transplanted 37. So small number.
Very small numbers, but also for the foreseeable future, this is going to be a living donor because people won't have MELD scores.
Waleed.
So question for you, Paul. So you witnessed hepatitis B evolution for many, many years, and we still don't have a cure. And we're finding out the role of surface antigen in making treatment decision. So two questions. One is surface antigen quantification should be part of standard of care for hepatitis B. And two, what price of side effect the future treatment will bear for these patients as we start using immunomodulator now as part of the armamentarium for hepatitis B.
Yeah, it's a good question as well. He's asking, should we be testing for hepatitis B surface antigen routinely? And what kind of side effects will be acceptable for new therapies? I mean, we do test routinely in the select population, again, of patients that are non-cirrhotic, e-antigen negative, on a nuke, undetectable viral load for 2 years, and normal ALT. So that's a select population. We do surface antigen titers routinely in those. And it's commercially available tests. We've never had any pushback on the test. So it's paid back. It's paid for. And we use that surface antigen titer to determine who we might take off a nuke. So as drugs get farther along development, if we get an approved drug, you're gonna use it a lot more because you're gonna be able to select patients that are more likely to be cured. As far as side effects of these drugs, the one difference between DAAs and Hep B drugs is the DAAs that we used and in PEG interferon, we had drugs that caused bad side effects and some were fatal. And that was acceptable for Hep C because we were treating a disease that was killing a lot of people, causing cirrhosis, liver transplant, liver cancer. It was a terrible disease, and we were desperate for new drugs. In Hep B, that's not true. We got nukes that work. And we've got hundreds and hundreds of patients on nukes that are they'd like to get off their nuke, but you can't knock anybody off with a new drug. So any fatal complication of a new drug, I think, would kill the drug. And so I think the checkpoint inhibitors, personally, for Hep B, I think that's like throwing a hand grenade in a room and just seeing what happens. I think that's kind of scary. The other drugs, the antisense oligonucleotides and all that stuff, they look like they're pretty well tolerated. So, but take an injection every day for 48 weeks is not easy to do. So it's not clear where we're going with this, but I think it's going to take it'll take a new generation of hepatologists. So with that, I'm going to cut us short and